Welcome everyone to City and State's very first Addressing New York's Most Vulnerable Summit. I'm Zach Williams, Senior State Politics Reporter at City and State. Thank you so much for joining us. We got a great event coming up with some of the sharpest minds around discussing how COVID-19 is affecting the physical, social, and emotional health of some of the most vulnerable New Yorkers. Before I introduce them, I just want to take a moment to thank our great events team and the sponsors that helped put this great event on. They include Somos Community Care, CDW, Getting Out and Staying Out, and the Urban Resource Institute. And just a few housekeeping points for everybody, just so you know, the chat feature, make sure it's set so that you're addressing everybody in the chat feed. If you want to share something, a point of view, if you want to address the actual panelists, though, make sure to use the Q&A box at the bottom of your screens where you can submit any questions, and we'll see if we can work them into the discussions as they come up. Now, let's get to our program. First up, we have Melanie Hartzog. She's the Deputy Mayor for Health and Human Services, where she's responsible for guiding the city's response to the ongoing pandemic. And she also oversees the social service agencies that serve seniors, the homeless, children, and victims of domestic violence. She's also had various roles at NYC Health and Hospitals, the Mayor's Office of Management and Budget, and the Children's Defense Fund. So let's just say she really knows her stuff on a wide range of issues affecting people across the city. Thank you so much for joining us.
Thank you, Zach, for that introduction. Just hearing my job repeated back to me, it sounds like quite a handful. So I just wanted to say good afternoon, everyone. And thank you, City and State, for organizing a conversation on this important topic. And thanks to my colleagues for participating on the panel discussion. As a Deputy Mayor for Health and Human Services, I work alongside our city's public health experts to monitor the evolving science around COVID-19 and implement data-driven responses to combat the disease, and to direct resources to support the city's COVID-19 response and recovery efforts. When people speak about the challenges that have emerged from the pandemic, you often hear that we're all in this together. But the impacts of the pandemic have not been felt equally across New York City. The pandemic magnified existing disparities among vulnerable populations. Communities with high rates of infection, hospitalization, and deaths also had a high percentage of other health and socioeconomic disparities that existed long before COVID. And for many others, faced higher levels of risk or stress, from working mothers who had to juggle childcare and work responsibilities and remote learning, to seniors with limited ability to engage in activities outside of their homes, to those struggling to address mental health challenges at a time when everything feels so uncertain. A just recovery for all is a guiding policy at the forefront of the city's effort to engage the communities hardest hit by COVID-19 and build back stronger, more just communities. The first step along this path is getting vaccinated. Not only is this how we keep ourselves and those close around us safe, but that's how we'll slow new, stronger variants from developing, like we've experienced with Delta. I am so proud to say that the city's vaccination program has worked to ensure equitable access to vaccines through an at-home vaccination program, a mobile vaccination fleet, pop-up sites in our 90 communities, and houses of worship are just a few examples of how we bring the vaccine directly to people who would stand to benefit the most. And as of today, 5.8 million New Yorkers, or over 70% of our New York City residents, have received at least one dose of vaccine. Our work to improve vaccination rates among Black and Latinos are also paying off. Since July, over 50% of all doses administered have been given to residents of the 33 hardest hit communities by COVID-19. The past few weeks, it's been closer to 60%. And over the summer, the vaccination rate among Latinos increased by 15 percentage points, and the vaccination rate amongst Blacks have increased 9%. Building on our vaccine equity work, we launched the Public Health Corps this week. The Corps are New Yorkers from the communities affected most by COVID-19 who will serve as community health workers within their own communities to deliver health education, community health interventions, create care connections to care, especially mental health care, and conduct clinic-based care management. As a city takes steps to begin to safely open, we must take stock of the inequities exposed by the pandemic and continue to seek solutions for the challenges that lie ahead of us. We've made progress in key areas, but I'd like to touch on a few examples of that. We learned this past year how people were affected mentally and emotionally from isolation and lack of resource access to vital services. At vaccine sites, through our mental health amplifier program, the city conducted emotional well-being check-ins with New Yorkers. Our amplifiers engaged 65,000 people in conversations about what they'd gone through with the virus and vaccine-related stress. We are also reimagining the city's response to mental health emergencies from a public health lens instead of public safety. We started with a pilot initiative in Harlem with the goal of expanding throughout the city over the coming years. Be Heard, our pilot, means that teams of health professionals, including EMTs, paramedics, and mental health clinicians, are responding to 911 mental health calls rather than police officers. Since launching in June, Be Heard has responded to over 300 mental health emergencies, and we've seen higher acceptance of services, more people receiving the assistance they need on site, and lower rates of hospital transport. Launching Mental Health for All and the Office of Community Mental Health are examples of how we will be focused on mental health for New Yorkers for years to come. And I especially want to thank one of our panelists at today's summit, Susan Herman, a wonderful, wonderful leader and a great partner in these efforts. I just enjoy my work with her so much, and she's done so much for mental health in New York City in terms of access and services. So I'm sure she'll talk more about all of her work very shortly. Throughout the COVID-19 pandemic, the city has worked to ensure that vaccines are available to New Yorkers in their homes and to ensure the homebound New Yorkers, disabled New Yorkers, and seniors have access to the resources they need during the crisis. The at-home vaccination program launched in March of 2021 has served more than 20,000 individuals. And since March of 2020, our Get Food NYC program has served over 225 million free meals and provided emergency home delivery to over 1.5 million New Yorkers. I know you'll all hear from Victor Calise today. I want to thank him for his tireless work on behalf of disabled New Yorkers and all of his work with us to set up all of our vaccine sites. Many older New Yorkers are struggling with new levels of social isolation compounded by the temporary closure of most senior centers, libraries, restaurants, and houses of worship at the height of the pandemic. The city has taken some important steps to support older New Yorkers during the crisis, including scaling up our home delivered meals, free transportation resources to our vaccine appointments, and bring mobile vaccine units to senior centers. We are working to expand our resources for older adults to continue to help them feel support beyond the pandemic. This includes a $58 million investment in the community care plan to expand aging services over the next 5 years. Under this plan, the New York City Department for the Aging will be adding new older adult centers in communities with large aging populations that are underserved. I'm sure you'll hear more about this from Lorraine Cortés-Vázquez. Lorraine is the strongest advocate that I know for older adults, and I'm really proud to work alongside her and the department. The rise in mental health issues has been described as a second pandemic, and this is a challenge we must continue to meet head on, connecting New Yorkers to one another and to critical mental health support, making sure our recovery doesn't just bring us back to where we were before COVID, but brings government closer to the most vulnerable. This is the moment we must seize, and I know so many of my colleagues in government feel the same. And I also appreciate that many of you participating in today's summit recognize that it will take all of us, not just government, to provide supports to our most vulnerable New Yorkers. Thank you so much to City and State for this convening and the opportunity to participate.
Well, thank you so much for that, Deputy Mayor. That was a great overview of so many important issues facing vulnerable New Yorkers. In lieu of audience applause, I'll just give you a little clap right here from my apartment. That was really great to kick things off. Now we have the opportunity to hear from some other special guests, Dr. Ramon Talaj and Henry Munoz of Somos Community Care, who will be discussing racism and inequality in healthcare. Dr. Talaj and Mr. Munoz, are you on right now?
We are.
Yes.
We were slightly ahead of schedule. I was so worried, but I like being a good timekeeper. Thank you so much.
Well, I would like first to thank Deputy Mayor for Health and Human Services, Melanie Hartzog, for her wonderful and important keynote, as well as City and the state, New York, for bringing together so many leaders around the biggest priority of Somos community care, ensuring health, equity, and wellness for all New Yorkers. Hello, my name is Dr. Ramon Talach, and I am the chairman and founder of Somos Community Care, a network of 2,500 Latino, Asian, and Black community doctors spread across all New York City. I am also a Dominican immigrant, a father, a primary care physician, an essential worker, and of course, a New Yorker. I mention this because who I am and who my fellow Somos doctors are matter. The language that we speak matter, the countries we came from matter, and the communities we belong to and serve matter. We are a network of immigrants, of diverse doctors and local trusted health advisors. And because of this, we are also the doctors who have brought over 1.5 million COVID-19 vaccine into New Yorkers' most vulnerable communities, the immigrant low-income neighborhoods of color that were hit first by this pandemic and have long been sidelined by traditional healthcare system. It is because of these communities, our communities, and the long-standing health disparity that I found Somos Community Care and Somos US with my friend Henry Munoz. We recognize that without preventative care that was local, affordable, and culturally competent, our neighbors were facing worse health outcomes, lower life expectancies, and a worse quality of life. We know that Latinos are more likely than any other racial group to use the ER and urgent care as their primary means for access to healthcare. And we know that our communities are more likely to bear the social determinants of health, like worse air quality in our neighborhoods, which are causing Latino children and young adults to suffer from asthma at higher rates. So while our communities are some of the most in need of quality healthcare, we also face a multitude of barriers to receiving it, from cost to linguistic barriers, geographic barriers, and even simply the lack of time to visit the doctor's office. Traditional healthcare was never built for people like us. And the failure of the healthcare system, the inequities, and the structural racism we face have produced a deep distrust within our communities of hospital, doctors, medicine, and treatment, especially preventive care. This is why we create Somos, to build a healthcare network for and by the people who look like us, speak our language, and share our stories. A network that will address healthcare needs before they become crisis. Therefore, Somos will continue his mission of taking care of the poor, feed the hungry, care and cure for the ill, and overall, treat the order the same way we would like to be treated. Henry, would you please take it from here?
Thank you, Ramon. And thank you, Zach, for introducing us. And thank you to City and State for tackling subjects that are very often difficult to address, like the idea of health equity and how to treat the most vulnerable people in this city and in this state. But I want to begin by thanking Ramon. You know, the word hero is not a term that I throw around a lot, but he has changed my life and the lives of many New Yorkers. And I think that's because of his resilience and his unique perspective. And I'm always going to be grateful to him for what he has been able to accomplish over the course of the last few years. You know, vulnerable is an interesting term for this purpose because I had to look it up. What does it really mean to be vulnerable in the American society? And what is its implications for people's healthcare? The truth of the matter is that in the United States of America today, not all lives are created equal. We know that for a fact. This is a picture I took on the very first day I ever toured a waiting room with Herman of people who were sitting together hoping to access healthcare on a Sunday morning in a waiting room, Latino waiting rooms, in Chinese waiting rooms in some of the poorest neighborhoods of New York before there was any talk of change to the healthcare system. And for over the course of the last 7 years, Somos has been working under a principle that you could treat poor people, treat immigrants, and bring quality and preventative care to their lives. And that has become 2,500 doctors of color who have organized themselves in an unprecedented manner for the United States. Doctors are usually individuals or associated with hospitals, but in this case, it's a grassroots movement of medical professionals, all of whom are minority. And that power has led to about 1 million patients who are being treated differently in New York today, because it's all organized around treating poor people and treating people of color with the same respect and the same dignity as rich people. And at the same time that we've been doing that, by keeping people out of hospitals, for example, we've been able to save over $300 million for the taxpayers of New York over the course of the last several years. And in many ways, because of that experience, we were ready to hit the streets when COVID-19 struck. This is a picture from the very earliest days of March, when we were setting up testing facilities and parking lots around the city of New York with very little knowledge of where this pandemic would be headed. Our doctors just decided to roll up their sleeves and to volunteer. We went to schools. We went to anywhere where our communities needed to be in order for us to keep them safe. Churches, NYCHA facilities, wherever it took us to test and now to vaccinate city employees, state employees, essential workers. SOMOS has been there. We even were given the opportunity to rescue some of the most important institutions. I was very proud of this day when our doctors rang the opening bell for the New York Stock Exchange. Imagine that, a group of minority doctors ringing that opening bell. And when COVID made it hard to put food on the table, we fed our communities. If anybody had told me that that would ever happen in the United States of America, I wouldn't believe them. And since January, we've been vaccinating people all over the city of New York, making sure that people understood that vaccinations is the only solution to be able to go back to a healthy community and rebuild the New York City that we all know and love. And we've opened over 175 vaccination sites throughout the city. We've been in the subway systems and public transportation systems of New York. We've been in some of the most iconic spaces in New York, Yankee Stadium. We've been in the community centers in those very same neighborhoods where we started 7 years ago, where people were too poor, didn't speak the language, were intimidated from being vaccinated. And recently, we just launched a new partnership with the Avengers, where we decided that if young children were having a hard time being convinced, getting vaccinated, well, we'd use some of the most iconic heroes in the history of our civilization to help lead them towards vaccination. And I'm very proud that we've tested now over 1 million New Yorkers. I'm not as proud to have fed over 2 million meals to New Yorkers. And as of last week, we have reached our initial goal of vaccinating over 1.5 million New Yorkers. And this is a group of minority doctors who were told at the very beginning of this journey that we had no role in reorganizing the healthcare system. And through all of this, what we learned, we conducted research and collected data, and we found that the impact of COVID-19 wasn't just on people's health, it was on their health and their educational opportunity and their jobs and their small businesses, and that you cannot separate the vulnerability of people's individual health from the vulnerability of the health of the entire city. And so we changed the way that we've worked, and our system seems to be working. We're grassroots, we go to where people need us. And we speak their language. We routinely treat people in Spanish and in English and in 2 dialects of Chinese. And we use culture to communicate to people because we understand that sometimes it's better to give people medicine with a spoonful of sugar so that they open their minds to what is coming next. And the truth of the matter is that that vulnerable population that we're talking about today is the present and the future of New York. When you combine the Latino community, the Black community, and the Asian community, it is the majority of the population of this state and of this city. So consider this, that's a picture of a phone that my grandmother used to keep in her bedroom. and there's the iPhone next to it. In the course of just a few decades, that's how technology in communication has evolved. And while science has evolved, the structure of healthcare has not evolved with it. So it calls for a new model that is not based on illness, but is based on wellness and keeping people out of hospitals. We have, can you go back for a minute? In order to understand that, we commissioned one of the first studies of the state of Latino health in New York City and the state of Asian health in New York City. And it taught us several important lessons that have led us to what we believe is part of the solution. That we need to become a social health network, and that there should be social health networks developed across this state and across the country. Networks that will inform and educate the vulnerable, that will go to the patients where they need it in a grassroots fashion. A space between the individual primary care physician's office and the hospital where somebody goes when they're critically ill. That we need to focus on preventative care and wellness and health, something that very seldom happens for poor people or for immigrants or for people who are vulnerable. And we need to speak their language and use their cultural patterns. In other words, the way to change the dynamic of healthcare in the state of New York right now is to treat people as our equals. And it's been an honor for me to spend the last few years of my life working with Ramon and the heroes of Somos. Now people call Somos heroes, and I think that they are heroes. But the truth of the matter is that this moment doesn't necessarily need heroes. It needs massive change. And that is what we're here to argue for massive change in the healthcare system that treats the vulnerable the same way that the rich are treated. Thanks, Zach.
Thank you so much to both of you. That was a great overview of all the work that Somos has been doing over the last year and a half now. It's hard to believe the pandemic's been going that long. And I think everybody in so many different ways has really thought of mental health in new ways during the pandemic. It's just really highlighted in so many different ways, whether it's just cabin fever from the pandemic or the very serious issues going on at Rikers Island and with mass incarceration. So many things going on, and we promised you the best minds on issues like this. And among them is Maya Kaufman, one of the best healthcare reporters out there, and she's going to be moderating our next panel that's entitled Tackling the Mental Health Crisis. Ready to go, Maya?
Yeah, all set. Thanks very much, Zach. So our panel will be about tackling mental health in New York. I'll introduce our panelists before we get started. We've got Rebecca Lynn Walton. She's the Senior Assistant Vice President of the Office of Behavioral Health for New York City Health and Hospitals. We've got Susan Herman, the Director of the Mayor's Office of Community Mental Health. We've got Abby Robinson Hobson, Chief Administrative and Finance Officer for Getting Out and Staying Out, and Dr. Carla Smith, Deputy Chief Executive Officer of the Urban Resource Institute. We were supposed to have Councilwoman Farrah Lewis. She's unable to join us today. So we'll move forward with our first question, and the panelists will also share a little bit more about their work and their organizations. What kinds of mental health burdens has the pandemic placed on New Yorkers, and who has been disproportionately impacted? Let's start with Rebecca.
Hi, I'm Rebecca Lynn Walton. I'm a Senior Assistant Vice President in the Office of Behavioral Health for the New York City's Public Health Safety Net System. I started my career as a child and family therapist specializing in trauma, substance use, and justice involvement, and I apologize for the very New York experience of a lot of sirens outside of my office. But I have also come to this because I've been in recovery for nearly 20 years, and that's because I have a wonderful life today because of the quality care I received as a very young person that allowed me to grow and thrive over almost 20 years. And so I try to bring this to my same work every day for the New York Public Hospital System. We have 11 public hospitals and 70 clinics across the city. We're in 5 boroughs, and we're here to bring care to folks. You know, one of my main things I had to deal with when I was clinician in the community was, if someone lost their insurance, what do they do? And I'm grateful every day that we don't turn folks away when they lose their insurance or when they don't have insurance or documentation or anything. We give them care. And so I think a lot of the same things that were going on before the pandemic were just worsened. Access to technology needed when everyone went home, if they could, to isolate in the beginning of the pandemic. Many of our patients couldn't do that. They didn't have the technology or the understanding for how to get online and get to those sessions. We had never done a telehealth session for the most part, except in small amounts before the pandemic, and had to stand it up in about 2 days. And have now done hundreds of thousands of sessions with folks. And so I would say our job was to keep the doors open, keep the care coming, get methadone deliveries with our partners to folks in the community as needed so they could isolate, get them to quarantine hotels, all of the ways people needed care, and make sure we did so with compassion and with understanding of the real experience people were going through.
Thank you. And let's go now to Susan Herman.
Thank you. And thank you, City and State, for hosting this. And let me also just at the outset give the same shout out back to Deputy Mayor Hartzog. She is an extraordinary leader, and we've all been extremely lucky to have her as Deputy Mayor leading these efforts. The Mayor's Office of Community Mental Health really has a bifurcated function. We oversee right now 26 programs that are across 13 city agencies that are designed to fill gaps in mental health care in innovative ways. We're not running the whole mental health care system. We are all about innovation, identifying gaps in care and trying to fill them. The other half of what we do really has to do with coordinating policies and procedures across city agencies to help benefit all New Yorkers, to make sure that New Yorkers get the access to mental health care, all New Yorkers, that they need. So that means we're working on policies and procedures across city agencies, sometimes between 2, 3, or 4, when we identify an innovation that would make a difference. So to answer your question, who was particularly burdened? I think you have to think about the same people that we've all been talking about, people who are isolated. 1 out of 3 seniors is isolated, homebound in New York City, not necessarily homebound, but living alone, and certainly more vulnerable to loneliness and depression. People who worked on the front lines may be suffering PTSD, anxiety, depression, and that's the front lines across a number of professions. And people of color who experience racism more profoundly during the pandemic, even than before, who have less access to mental health care, may live in a mental health care desert. But I think when you think about it, we should be asking ourselves, who had a hard time being connected to care before the pandemic? And anyone who had a hard time being connected to care before the pandemic had a harder time during the pandemic. And at some point, I'd like to say that if you think about people who have serious mental illness, they had a particularly hard time staying connected to care. And I'm sure we'll get into a little bit later what was done to help people in a variety of circumstances.
We'll go now to Abby Robinson Hobson.
Hi, thank you for having me. Thank you to City and State. Again, I'm Abby Robinson Hobson with Getting Out and Staying Out, GOSO. And I just want to say what brings me to this work is my decades of experience in the business sector, but my interaction with the homeless population as I traveled to and from work in the subway. And what I found personally was that very often the homeless population, there was mental illness there. And the other common denominator was that very often they had been incarcerated. And this is by me personally speaking with them in those years traveling in a subway. At GOSO, we provide services in that very area: emotional well-being, education, and employment. We serve approximately 1,000 young men ages 16 to 24 that are justice involved, many of whom are from neighborhoods that were extremely hit during the pandemic. Our approach is unique in that we work with each participant, we pair them with a social worker, and we get to know them and work with them on their goals. While GOSO provides services including mental health care for our participants during the pandemic, honestly, prior to the pandemic, this issue was there. The pandemic just exacerbated the conditions that were often already difficult for the individuals we serve. And there are three major areas: technology, loss of employment, and the increased barriers of basic needs. And when I say technology, I'm talking about people that didn't have access to telehealth, didn't have cell phones and laptops. So GOSO was able to provide that service and that technology to our participants so they can get these services here at GOSO and otherwise, so that they can have internet service or stable internet service, providing them with hotspots and laptops and cell phones. I mentioned loss of employment. As we know, loss of employment can lead to extra stress as it relates to finances and increase general depression and anxiety, just as many of us may have. And this we found increased in this population. And then I mentioned increased barriers, basic needs, things like a birth certificate, social security card, state ID. This snowballed into being a major issue for our participants, because without that, you can't obtain employment, or you can't go to school or go to a training course. So these were just some of the things that we found to be heightened during the pandemic. People with mental health illness have been criminalized well before the pandemic, and this is a longstanding issue that must be addressed. An estimated 20% of individuals in jail and 15% of individuals in prisons struggle with serious mental illness, despite the fact that only 4 to 5% of the population imprisoned that's not imprisoned is mentally ill. So that disparity of those imprisoned to the total population is just appalling. Approximately 2 million people are arrested annually and have been diagnosed with mental illness. And the risk of being arrested is especially heightened for Black and Brown people with mental illness. And almost 30% of people who've been jailed 3 or more times have mental illness. So these are just some of the things that have been heightened during the pandemic, but it has really been there. And GOSO works with our young people in these areas through, again, working with them, with our social workers and mental health and education and employment.
Thank you. And now Dr. Carla Smith.
Thanks, Maya. Good afternoon. As mentioned, my name is Dr. Carla Smith, and I have the pleasure of serving as the Deputy CEO of Urban Resource Institute. We want to thank City and State for inviting us to participate in this important conversation. As you may know, URI is currently the largest provider of domestic violence shelter services in the country, and we're also a respected provider of shelter to homeless families. We remain dedicated to operating programs that are designed to break the cycles of violence, poverty, and trauma experienced by so many of the vulnerable populations who reach out to us and come through our doors. With respect to the first question, we have witnessed firsthand through our work the impact of the pandemic on the individuals we serve. Some of those issues have already been mentioned by others on the panel, but I will just speak specifically around victims of domestic violence. As you all probably remember, at the beginning of the pandemic, we were all sort of instructed and guided to stay at home. And this may be the way to operate to keep people healthy and safe for many, many people, but for victims of domestic violence, this can be significantly more dangerous if they are living with their perpetrator. We know this because largely abuse thrives in isolation, and more time at home gives abusers the opportunity to exert control, knowing their partners have less options of escaping, and thereby exacerbating some mental health issues and isolation. We've had lots of calls coming through our hotline, letting us know people were in their bathrooms on the floor, running water, trying to get help, trying to get safety and trying to do safety planning so that they could have a moment in time where if they wanted to leave that relationship, they could gain access to shelter. But also balancing that with the fear around what shelter might look like, right? Were they going to be in shelter safely during the pandemic? So we spent a lot of time sort of educating around that. URI also operates a relationship abuse prevention program in partnership with the mayor's office and the Department of Education in New York City, where we're providing education around healthy relationships and domestic violence to middle school and high school students. We know that these students were largely being educated at home. They were unable to socialize. They were also more likely to be exposed and subjected to violence and stress in the home, whether that be economic related stress or otherwise. This created additional trauma. We saw a lot of reported suicidal ideation that required immediate interventions. And we also work with abusive partners. So we know that ending domestic violence also leads us to working with abusive partners in order to hold them accountable to the abuse that they've perpetrated, but also to acknowledge the fact that about 80% of those who are mandated to participate in our programs have experienced trauma themselves. And so we offer a in-person, pre-pandemic, an in-person innovative program that includes wraparound services. So not just addressing the accountability and doing education and behavioral based modification work, but also meeting those particular needs that they had around food insecurity, around access to employment. And so we had an office that was filled every day by individuals who participated in those programs, and not being able to engage in that face-to-face in person. You know, we had concerns around accountability and how safe we were going to keep our victims who they were perpetrating violence against. And so there was a lot of work we had to do in order to modify programs. And I know we're going to talk a little bit about that as we move forward. Thanks, Maya.
Thank you. So for our next question, I want to hear about what have been the challenges for especially vulnerable populations in accessing mental health care during the pandemic. So for example, people incarcerated on Rikers Island, those in domestic violence shelters and homeless shelters, and people with substance use disorders. And let's start with Dr. Carla Smith. Let's go in the opposite direction this time.
Sure. So I'll just spend a few moments just reiterating the challenges that we saw early on in the pandemic and over time, over the last year. At the beginning of the crisis, we saw domestic violence calls and requests for assistance drop. That did not, of course, mean that incidents of domestic violence were not taking place. We knew that victims were constantly assessing risk factors as it related to their safety. They had to make the tough choice of weighing the risk of staying at home with their abusive partner who they knew, and often, in many cases, knew how to stay safe within those situations versus sort of the unknown of coming into shelter and what that might look like for them. We also knew that access to mental health providers during that time was really challenging because they were in the house with their abusive partner, who also may have been dealing with stress related to job loss and things of that nature. So getting out for services was really challenging. Being able to make those phone calls was really challenging. How were they going to reach out to us in order to keep themselves safe, to potentially come into shelter? That was something that was very challenging. And so we did a lot of work in order to develop safety plans and communicate through the media to make sure that people knew our doors were open and to dispel sort of beliefs around what shelter might look like. We offer shelters that are apartment style living. And so they do get their own apartments, which could keep them safe. And we had a lot of safety measures in place with respect to opening the doors to that population. I'll turn it back to you, Maya.
Let me look at. Yes.
Abby Robinson Hobson, let's hear from you.
Nothing positive comes out of criminalization and incarceration. It leads to or exacerbates mental illness. The issue at Rikers right now is been deemed a humanitarian crisis. You know, it may have been increased by the pandemic, but Rikers has always been in a crisis. For mental ill people who've been incarcerated, we've long time gotten this, they never get the services they need. COVID meant that this was more heightened, more known, and these people were further neglected from their families. They were isolated. Visitation rights were non-existent. Medical care had been almost impossible to obtain. If they got out of housing, and jobs were very often harder to get. And this was faced with longer wait time for court appearances. The court system was behind. We have the case of Isaias Johnson, who had 3 court appearances that he was not taken to court and was left at Rikers for $1. His bail was $1 and his family could have paid that. So these are just some of the things that have been heightened during the pandemic and where we are now, but this has always been a crisis. And among our participants here at GOSA, we've seen that mental illness has long-lasting impact on the trajectory of their lives. As children, they are often don't get the help they need, finding themselves labeled as problem children or a problem child, problem kid. And as they get older, mental illness makes it even more difficult to obtain employment. And as we know, employment is a prerequisite for housing. So there you have the homeless issue. This is far too long, has been an issue, and far too many mentally ill people are homeless. And that's just where we stand, and where I personally stand and where we stand at GOSA in regards to this topic.
Susan Herman.
Well, thank you. I would say again that a group that was especially hard hit was people living with serious mental illness. But at this point in the conversation, I'd also like to say that that's not a monolithic group. We tend to all have images in our heads about who it is that has serious mental illness. And those images typically are a whole lot narrower in breadth than the population that has serious mental illness, all of which have had a hard time accessing care during the pandemic. So it's the 80-year-old person who lives alone and is homebound and maybe now has chronic depression and maybe did not before because it's a little bit easier to have some social connection. It's the high school junior who's gone through what we all know our students and our young people in New York have gone through the last 18 months, who maybe now is experiencing the first symptoms of psychosis. First time. It's somebody who was a victim of a gun shooting in New York City, who maybe is struggling with PTSD and significant depression that's lingered for months, that has become quite dysfunctional as a result. That person may be suffering from serious mental illness. And it is the person who might be suffering from chronic street homelessness, who may have bipolar disorder or some other pre-diagnosed, or now needs to be diagnosed serious mental illness. But it's also the person who has experienced multiple hospitalizations, who has had and always has had difficulty staying connected to traditional outpatient treatment after a hospitalization. During the pandemic, that became even harder for many people to think about going on, how am I going to get there? How am I going to get to that clinic? I have or I don't have a cell phone. All the barriers that existed before. Is it culturally responsive? Does it speak to me? Now is it open? Now can I get there? I understand there's telemental health. I don't have a laptop. I don't have a cell phone. There are fewer people working in that place. They're not there. The hours are shorter. So there's a whole lot of people. In many ways, the most vulnerable people in terms of mental health were people that either had or developed serious mental illness during the pandemic and therefore had an even harder time staying or getting connected to care for the first time. And I just think it's really important to broaden this image of who needed help and who needed significant help. Where were the gaps in mental health care that all of us needed to be looking at?
And we'll go now to Rebecca.
Thank you. I think this panel is really highlighting the tremendous amount of work that has been done and the tremendous amount of work yet to do. And I know that as New Yorkers, we really just want to jump in there and fix it and solve it for other New Yorkers. And I definitely have seen that throughout the pandemic, from the first day we shut things down all the way till now, and really trying to provide that support. You know, for a lot of us, I know I got COVID in March of 2020, along with a lot of other people. And so we were working around the clock anyway while trying to figure out what COVID symptoms felt like to provide this care. And then as unfortunately some of us have gone on to develop long haul syndrome, or whatever it's called today, because we're coming up with it as we go, we've tried to support one another through that. And so sometimes it's meant making sure that the emotional well-being of New Yorkers is cared for, and sometimes that's our patients, and sometimes that's our workforce. And so I know that those of us who were not in the ICUs and those units during spring of 2020 immediately bounced into action. How do we get care? How do we get respite rooms? How do we support our colleagues who were focused on that, whether it was our job or not? How do we have hotlines for folks? If I'm sitting at a desk trying to figure something out, I can also take a crisis counseling call from a staff person so that they can go on, because a lot of times in the beginning, especially, healthcare workers were the people providing that emotional support that family members generally provide to someone who's unwell. And so we had to figure out a new way of doing it, a new way of supporting those efforts. And I think it's been tremendously successful. We definitely, as what I'm hearing everyone's talking about, is we know the populations we are committed to serving and passionate about serving, and so we know what the issues are. And so from day one, we were fighting to get phones and data plan, not fighting, asking nicely, repeatedly, and then got it very graciously from folks to get phones with data plans for patients. We could go over how to do sessions with them. They could come in for that first session if they really needed to, and we could spend that session going over on the phone with them how to access a session, and then from then on they could stay home, or they could send family members to do it, or have a family member with them as well. And then we could also have them with that data use that same data plan to do interviews for housing and all of the things that go into the complicated and exhausting life that it means to be vulnerable, because that's what I think about when I think of vulnerable populations, is the tremendous amount of work and effort and the full-time job it is to get the basics in your life. And so the more we can lift that off of New Yorkers, the better service we can provide for them.
So we've talked about the challenges and the mental health burdens. I want to shift now and talk about the delivery of care and some examples. So how has the pandemic shifted the delivery of mental health care and care for substance use disorders? And what are some examples of things that the city or your organizations have done? So I want to start with talking about examples of how the city adapted to providing mental health care and substance use disorder care. Let's go right back to you, Rebecca.
Great, because that's what I work on every day, proudly. So, you know, in March of 2020, we were on the phone with our shelter system, our state substance use system, Office of Mental Health, the city, and we were all on the phone trying to figure out what is the system, who do we need involved, and we came up very rapidly, thanks to a lot of hard work around the clock from folks, with how to have a methadone delivery and how to get medications and buprenorphine and other medication-assisted therapies to folks, whether they were in isolation hotels or home, or if they needed the state very quickly relaxed the ability to provide larger amounts of medication to folks who were in substance use services, and how to help them safely isolate at home if need be, and then how to keep the doors open as well. We were right there from the beginning trying to figure out how do you do safe groups, because that is such a healing support for folks in substance use, and how to do it both remotely and then also for people who need to come in person, how to do so safely. And so I just remember one of our facilities sent a lot of pictures and sort of a graph to the state for this is how we're proposing to do it safely, and then that was the way that the whole state moved forward with it. And it was really a lot of innovation on the ground from people at all levels, patients sharing what did and did not feel safe as people have become vaccinated and waiting rooms have filled up again, helping figure out how to space that and how to help people feel comfortable and deal with that anxiety. You know, it didn't used to make me feel nervous sitting in a crowded waiting room. It does now. And so I recognize that patients may need some extra help. New Yorkers may need some extra help with that. And so it's really just doing what's needed where it's needed, and also understanding that someone may not have the words to describe what's going on because they've never dealt with this before. And so someone may come to their private care for their first post-COVID appointment and not understand what anxiety is, and not understand until they can breathe again that they're feeling anxiety in the first place, because they're so focused on can they breathe right now. And so understanding that you need to provide behavioral health support right there in the first session, but it may also show up 6 months down the road and be there ready to hold their hands then as well.
And going to you, Susan, how has the pandemic shifted the delivery of care, and how did the Mayor's Office of Community Mental Health adapt?
So let me give you some examples. I'll elaborate a little bit on some of what Rebecca said, but some examples of things that shifted at the very beginning of the pandemic, and then hopefully some things that we'll be thinking about going forward. First of all, right away, we added capacity to NYC Well, because we knew that people would be calling our helpline, our 24-hour helpline, to seek care right on the phone or through chats and texts, or to get referral and to just ask questions about where can I get help, and to talk about what they were experiencing. Every single month has had a higher volume than the same month the year before going forward. All of these months still, since the pandemic began, that volume has increased and increased and increased. Every single month is higher than the same month the year before. I also want to talk about telehealth. I think Rebecca said, you know, we learned quickly, we jumped into it, but I want to underscore what she's saying. Before the pandemic, the month before the pandemic, Health and Hospitals had conducted a total of 500 tele-mental health sessions at any time over a period of years. 3 weeks, not months, 3 weeks into the pandemic, they'd conducted 57,000 tele-mental health sessions. That's quite a pivot. It's extraordinary, and they deserve a lot of credit for this. And then there are some sort of creative things that they found and others found to do to adapt services to help people in new ways. If our mobile crisis teams, for instance, which are teams of nurses and psychiatrists and peers who can go to people's homes where there's an urgent need, and they go and they assess the situation. We've added capacity to the mobile team so that they can be there typically within a few hours. They get there. If during the pandemic we were seeing, and Health and Hospitals also took the lead here, we were seeing that many of these teams had lower caseloads than they had before. Just at the beginning, maybe they could provide another function. Maybe they could actually start bringing medication to people who were already known to Health and Hospitals, who otherwise might miss an appointment and not get their medication. So that's another sort of pivot that was really important. Another thing I would say is that our mobile treatment teams, which provide mental health care in the community to, again, to people who have serious mental illness, who have a hard time staying connected to traditional care in brick and mortar clinics. So we go to them, and those teams are teams that both community-based organizations run and teams that our public hospital system runs. They send out mobile treatment teams to find people, work with them where they are, and help them stay connected to care. What did they need during the pandemic? They needed more information about housing, more information about, eventually, about vaccination, but they needed more information via cell phone than ever before. And so we did provide cell phones. We did try and reach them in ways that we hadn't before, so we could stay connected to people who otherwise might be struggling even more than usual. So there was a lot of pivoting at the government level, and there was a lot of pivoting at the community-based level. One of my favorite examples is one from the Red Hook Initiative, who had social workers who were used to seeing people inside in their offices, who realized, of course, they're not going to come in, and they shouldn't be coming in. And so they set up at a picnic table in a park in Red Hook and let it be known that the social workers were out in the park. And if you wanted to see them, they're out there. And so it's providing mental health care wherever we could, being creative, using resources in new ways, and figuring out ways to deliver mental health care. And everybody did it. Everybody rose to this challenge. In our programs that we oversee in our office, all of the programs that have any sort of residential services continued to provide mental health care. So the not just the drop-in centers, but the residential centers that the Department for Youth and Community Development runs for runaway and homeless youth, they continued to provide their mental health services. Our city's shelters that have mental health services continued to provide them. Anybody who was in any sort of a residential program had on-site care. If you weren't in a residential program, but you were connected to care, say in our senior centers where we have clinicians, they went remote, and they went remote very quickly. So that the pivoting was really amazing, and sort of one of the untold stories of the pandemic. It's people who just kept going.
And Abby, let's go to you to talk about how getting out and staying out adapted in delivering mental health care.
Sure, thank you. You know, at GOSO, our core program operates from a social work model, as I've mentioned. Each participant is paired with a social worker to discuss their specific and individual needs and their goals. Our social workers sit with our participants and ask questions and understand the full person. So here we go, we were in mid-March, and we were like, how do we continue this? The tech divide, the technology divide became more apparent. So as I've stated, we quickly shifted where we made sure that for the participants that we were already providing technology to, fine, but for those that didn't have it, shifted in that every single participant now had to have some form of technology via laptop, cell phone. And we did this via Zoom. So from the months of March, mid-March to June, we did all of this via Zoom, and we didn't skip any services other than the in-person services. We would typically have individual weekly counseling sessions or a variety of pro-social groups. And we continue this, but via Zoom. And then during the pandemic, also, we just gave the option to still continue it individually through Zoom or on the phone and in group sessions. So for us, it was really important to shift. to the virtual model for those months of March through June. And in June, we were back in the office, working with our participants in a hybrid way. So understanding that a hybrid way could work, and very often we would do virtual or in person with the specific safeguards in motion. So for us, it was clear that to be nimble was important, and to shift immediately in mid-March and provide services at the exact potential that we had been through those months, and then subsequent to June, having that hybrid model. And that's what we found work, and that for each of our participants.
Now, Dr. Carla Smith.
I think this conversation is just really reaffirming in terms of all of the panel members' commitment to ensuring that New Yorkers had access to services, and how inventive we can be as organizations when having to come up with resources to open the doors. URI, I think, did the same thing. So we immediately shifted services largely to a virtual setting. What does that mean in shelter? It means we had to have a huge amount of investment on the IT side. So hundreds of thousands of dollars of investment in terms of making sure that we had Wi-Fi access, that we were partnering with the city, the Department of Education, the state, to ensure that all of our students had access to iPads, that our abusive partners had access to cell phones and tablets so that they could engage in accountability groups and one-on-one clinical sessions with their caseworkers and their clinicians to ensure that they were having ongoing access to those services. One of the other things that we tried to do immediately, understanding, as I mentioned before, the challenge that individuals who were at home with abusive partners in terms of their ability to access services, one of the things that we did was to survey victims of domestic violence who were coming into shelter early on in the pandemic, to sort of understand what their thought process was in terms of accessing shelter and their ability to do that. Did they experience barriers? What were those barriers? So that we could then use that data to help inform the city and the state around different ways we needed to be able to communicate with potential victims who were out there, so that they could know that the doors remained open, and that we were here for them, and that we offered safe space, and that coming into shelter did not mean they were going to be impacted by the virus, right? That they were not guaranteed to get COVID if they walked through the doors of the shelter. They would walk through that door and get services and safety. And so we did share that information with the larger community, specifically the state, and then put those steps in place to ensure that we were communicating and that the doors could stay open to them. The other thing that we did was making sure that our families who did not want to leave their units had access to televisions in every single one of our units. So brand new televisions so that we could engage in activities with them. They could do yoga, they could do things online with their kids that were recreational and sort of relieve some of the stress other than having to sort of educate their kids, which was a new thing for them to be doing, right? Parents aren't naturally educators in all shapes and sizes. And I don't know how I would have felt having to be home with my children 24 hours a day and being their teacher in a way that I hadn't. So we wanted to give them an outlet. And many of the families were afraid to go outside. And so we wanted to make sure they had access to those materials that they would need in order to be able to engage in those activities. We also uniquely, URI provides access to shelter for victims with pets, right? So this is a unique, innovative program, making sure that victims who have pets, and pets are part of the family, can access shelter. So making sure that they knew when they came in, we would be able to take care of their pets, make sure that their pets had access to services, including vet services, behavioral modification services, that we could bring those services in-house safely, and we could socially distance in doing so, but that their animals as family members would be taken care of as well. We also wanted to offset sort of the stigmatization that went along with testing positive in shelter, right? And so understanding that if you tested positive, we wanted to maintain confidentiality, but we needed to keep individuals safe. So making sure we had systems in place in terms of notification within our shelters to both staff and clients around someone testing positive, and that, you know, we had isolation procedures in place, that we could bring food into families, that they did not have to worry, and that we could support the families through what it meant to be testing positive, and to make sure that they had the support that they needed as they move forward.
I want to turn down to the future. What advances are still needed in mental health care going forward, and what needs to be improved? Let's start with you, Rebecca.
Yeah, my first thing is I just make a plea for all that we've come up with during this pandemic to keep going. The access to phones, to tremendous support from the mayor's office, from all of the supports that we get from the state with getting people access to the tools they need to be successful in their care continue. It was tremendously successful being able to do virtual inductions to get people on medication-assisted treatment without having to have them come in. That's been great. We started, someone grassroots who does clinics at Bellevue started the very first virtual Bupe clinic we had in our system, and we kept going, and that was in large part to support from the system champions and city government partners helping us and state regulators making that possible. So I hope that continues. I hope the recognition that care needs to be flexible and we always talk in social work about meeting the client where they're at, but that needs to be much more flexible. I love the word nimble that was used earlier, because we need to figure out, if I'm coming from a primary care visit, maybe that's the best place to get my other care. Having support for staff where they could do virtual sessions while they're on their tour has been tremendously successful. I hope that continues as well. And really just recognizing the true community. This is happening to all of us. And so if I help my neighbor who may be living on the street right now get their care, they're still part of my community. And because I'm domiciled, I need to put my hand out all the more. And I think that has been the attitude that's happened, and I've been tremendously grateful to be part of this. And so I hope people take that attitude and that passion and excitement into the next phase as well, and think about care as something that all are deserving of, and remove the barriers by continuing the good effort we've come up with. We came up with a lot really quickly and then kept working on it to perfect it as we go along, and not perfect it because we still have a lot of work to do, but let's keep it going and let's keep this excitement going too. Thanks.
I want to turn to Susan now, and then also add into this question something that came in from the Q&A about telehealth. And so thinking about the advances still needed in mental health care, what are some of the advances needed in telehealth options, and in making sure that that level of care doesn't drop? So we'll fold that in, and Susan, go to you.
Okay, all right, thank you. Let me start by just giving a little bit of context. There's so much attention right now to the mental health of New Yorkers, in large part because of the pandemic. There was a increased conversation. There was a broader conversation before the pandemic. We've had more conversation to try and decrease the stigma around mental health, but the pandemic has really shined a spotlight on mental health as a byproduct of COVID, that mental illness, mental health challenges are something that we're all going to be facing. And all of us are dealing with this. And my hope is that the engagement in this issue and some of the resources that have been devoted to this issue are sustained in the city going forward, that the city keeps this kind of focus on mental health care. Just to give you some context on where we were and where we are now, we've added 2,200 units of permanent supportive housing for people who have serious mental illness between 2015 and now. 2,200 more units of supportive housing. Only 3 or 4 years ago, if you had an urgent need and you called NYC Well, and it was determined that you need somebody to come to your house to conduct an assessment and maybe de-escalate the situation, refer you to care, it might take up to 17 hours. That was the average to get there. Now, between 8 and 8 p.m., 8 a.m. and 8 p.m., 7 days a week, you can get a mobile crisis team to come to your home for what I call urgent needs, right? You don't need somebody within minutes, but you have a crisis and it's an urgent need within almost 2 hours all over the city. That's an extraordinary thing to be able to say in a city of this size. We've also, between 2015 and soon in the coming months, we will almost double the number of city-funded mobile treatment teams that we have in the city. Almost being able to serve at, when we reach our peak of 82, that combines city and state funded, actually we'll be able to serve over 5,300 people through our mobile treatment teams. So these are tremendously effective programs. 90% of the people who are in our intensive mobile treatment teams have been engaged and connected to care for more than 12 months. That's extraordinary statistics, extraordinary success rate for working with people who have had difficulty staying connected to care. And as we have discussed in other city and state forums, we are currently engaged in really reimagining our 911 mental health crisis response from a predominantly public safety oriented and emergency department oriented response to one where, whenever possible, we are focusing on the health need and having a health-centered response to 911 crises. So much of this work happened and has been escalated during the pandemic. And my hope is that it all continues. But something else that's particularly important that has happened is that we have named, identified 33 communities, 33 neighborhoods in New York City that were not only hardest hit by COVID, but have historically had healthcare inequities, suffered healthcare inequities. And those 33 communities are getting extra attention now in terms of our healthcare system, in terms of our mental health care delivery. Not only have programs shifted focus so that they're making sure, if they weren't focusing on those communities predominantly before, they are now, but where we are adding programs, we're really focusing on those 33 communities. So for instance, the Department for the Aging is about to expand the number of senior centers that will have clinicians to serve people. And that entire expansion is going to be within those 33 communities. We've also all been very aware and focused on the mental health needs of our students and our young New Yorkers. And for many, the new school-based social workers that have been added to our public schools throughout the city will be able to support them and help them. And we'll be running groups, and we'll be doing all sorts of things to address people who just need a little bit more attention to adjust well. But where there are students who have acute needs, we've created a new expedited referral system between our public schools and our health and hospitals, child and adolescent clinics. We've started in 5 districts that are in these 33 communities, and soon we hope to ramp up until we are in all of these communities and eventually throughout the city, so that students who need help get the help they need as soon as they need it. These are issues and programs and services that came under added scrutiny and questioning and got added attention during the pandemic because we knew that there were more people who would have mental health needs and challenges. But what I think we're all saying is we hope that this attention to mental health care continues beyond the pandemic.
Abby, let's jump to you to talk about what advances are still needed.
Sure, thank you. You know, while we've seen that the positive benefit of a hybrid model and a virtual model has worked in our community, the fact is that for incarcerated people, the level of overall care and mental illness care has always been abysmal and has only devolved more during the pandemic. More really needs to be done in this area. We are in a disastrous humanitarian crisis. Systemic change is needed overall, advocacy, decarceration, and services. Services has to be more, there has to be more services for the benefit of people with mental health issues, more resources versus more incarceration. Far too many people are incarcerated and do not have access to resources. And once they're let go, there definitely aren't any resources. We believe that decarceration, along with an investment in a strong support system, stable housing treatment, and employment opportunities is much of the answer. Getting the benefits of a network of services like GOSO means that you are less likely to have, and this will show itself in the less likelihood of recidivizing. You know, we've seen firsthand at GOSO how alternatives to incarceration like our programs can provide a lifeline. We provide tools for young people, including counseling, as I've said, job readiness for employment, connection to job training, education, and that leads to meaningful employment. We've seen how essential it is for our young people we serve to know someone is there for them, again, with that support system to help them through these difficult times and the trauma that they've experienced, supporting them through many of the challenges that they face in life. And the last two things I'll say is that police cannot be tasked with being first line of defense since they're not sufficiently trained with mental illness, right? So they're not trained to identify or deal with the complex nature of mental illness. And lastly, we just have to stop treating, our community has to stop treating mental illness and events of distress with police force, and instead invest in the social services that our community deserves, treating everyone with respect and that they desperately need. We must restore dignity to those living with mental illness.
And we've just got 3 minutes left. Let's go to you, Dr. Carla Smith, talk about what advances are still needed.
Yeah, so above and beyond sort of what's been mentioned already, we've heard a lot about resource investment, and the city has been amazing with respect to investment in resources to help us actually support our frontline workers doing this work, right? And if we don't have the frontline workers, we can't provide those services. So having access to those resources are really important. The other thing we've started to do is have some continued conversations around flexible funding models, right? And we need to be able to continue those type of conversations so that when pandemics or crises happen, organizations can easily shift the use of resources without having to go through some sort of administrative burden in order to be able to respond. Being able to move quickly, somebody said nimble, a couple of people have said nimble, is important. And it's vital for us to be able to be successful in providing access to services. Not having flexible funding models doesn't really enable us to do that as easily as possible. So those are the additional things I would add to the conversation based on what's been said so far.
Great, thank you so much. And thank you so much to our 4 panelists. We're running out of time, so I'll bring it back to Zach to introduce the next panel.
Thank you so much, Maya, and thank you again to all the panelists. That was a really great conversation. In lieu of audience applause, a few claps from my apartment. Thanks again, really appreciate it. And next we have Kristen Malek, Director of Business Diversity at CDW, who's going to be moderating our second panel on how New York is making disability rights a priority. Kristen?
Hi there, thank you for the introduction, and thank you so much to the panel right before. I found myself taking many notes, and there is such a promise of progress. And so thank you for all those contributions. It is my privilege to host our next panel, and I see all our panelists coming in now on screen. So good afternoon or good morning or good evening, wherever you are joining us from. Thank you for being here. Our panel is how New York is making disability rights a priority. And what I heard on the prior panel, one of the panelists said, this is happening to everyone. And as simple as those words are, I was in my room and I just paused and said, yes, this is to everyone what is happening when we look around our circumstance and environment and the disability community as well. So, it is a privilege to host this panel. I'll have our panelists, introduce themselves here in a moment. But I want to share, I'm really looking forward to this panelist as an audience member too. My 12-year-old daughter, Caitlin, has Down syndrome. And so this is near and dear and personal for me too, that we have conversations such as these that we'll have. So I promise not to get emotional, but this is my family that we are talking about, as well. So with that, I will, with my pleasure, turn it over to Commissioner Victor Calise for an intro, and we'll go from there.
Hello, Kristen. Thank you for sharing about your daughter. We are happy to have her in our community. My name is Victor Calise. I am the Commissioner of the Mayor's Office for People with Disabilities. For those who may not see me, I am a white male with black glasses, slick back, long COVID hair, blue shirts, and a blue blazer. And I am a wheelchair user. I, as mentioned, Commissioner of the Mayor's Office for People with Disabilities for the last 9 years, and my job is simple: to make New York City the most accessible city in the world. And we do that by working across agencies throughout the city. It could be Department of Transportation, Parks and Recreation, Cultural Affairs, Department of Buildings, and one of my colleagues, Christina Foti, Department of Education. So we work closely with them on lots of issues to look at every aspect of New York City to make it accessible. Our 7 areas that we concentrate on are healthcare, employment, financial empowerment, housing, transportation, everything the city has to offer, and education. And you could look up some of our information by an annual report that we put out called Accessible NYC. Thank you.
Thank you so much. If I can turn it over to Ms. Christina Foti for an introduction.
Of course. Good afternoon. Thank you so much for having me. Thank you, Commissioner Calise, and thank you, Kristen, and thank you to my colleagues on the panel in advance for the conversation. I'm Christina Foti. I'm the Deputy Chief Academic Officer at the Department of Education, overseeing special education services for our students with disabilities throughout New York City, and very happy to be here with you all.
Thank you so much. I'm just going to run my screen. Senator, we have you an introduction as well, please, sir.
Thank you for having me be a part of this. I appreciate it. My name is John Manion. I'm a newly elected New York State Senator. I can say that, 9 months now, and I came from the world of public education. I taught biology and chemistry for a long time, but I also was a teacher association president. So I represented a lot of teachers. I also taught in a 15-to-1 classroom. I'm a parent of a child with a disability, and I am the chair of the newly established Disabilities Committee in the New York State Senate.
Thank you for your service, sir, as well. Mr. Gregory, we turn it to you, sir, for introduction.
Hi, everyone. Thank you so much for having me. My name is Gregory Mellon. I serve on the board for the New York Association of School Psychologists. I'm really, really grateful to represent New York City psychologists specifically. I want to send a really, really big shout out to our school psychologists, to our mental health team, social workers and counselors, even to our school administrators, and even to our families and our parents who are having a difficult time transitioning, but we must transition nonetheless to helping our children reintegrate back into schools and becoming academic students. Really grateful to be here with everyone.
Thank you. Thank you for your work. To round us out, Mr. Jose Hernandez, please.
Hello, my name is Jose Hernandez. I am the NYC Advocacy Coordinator for United Spinal Association. I'm also the president of its New York City chapter. And just like Victor Calise, I am a wheelchair user due to a spinal cord injury I experienced at the age of 15, close to 26 years ago. I work for an organization that advocates for individuals with various disabilities. And Christine, right? You said something at the beginning that says the last panel ended by saying we wanted to include everyone. And I just want to address this right off the beginning. I want to thank City and State for putting this together, and we have a lot of people on, but we are kind of leaving out a population of the individuals with disabilities, as we don't have closed captionings or an ASL interpreter. So, just I want to put that out there, and we can't be inclusive and sensitive of everyone's issue if we don't give everyone the tools necessary to be able to participate fully.
Thank you for the intro, and I'm so glad that you mentioned that. I think probably the team at City and State are, tracking that down, writing a note, and we'll make sure, right, that that's a lesson going forward. We can learn when we listen, right? That's what moments like these are for, when we are using our time, all of your time, to share experiences, capability, capacity, services, and it's to say that not everything is perfect, not everything is as it should be. That's why we have moments like these, so that we can move forward. So thank you very much for sharing that and sharing the feedback. As I look to prepare for this, and of course manage my emotions through this, looking at just 1 million New Yorkers identify, right, of having a disability, that can seem like such a large population to serve. And so, Commissioner, I thought I would start with you. You have shared previously, you work on engagement, employment, education, and those three things really anchor you to delivering services. So I wanted to see if we could lead with you on what is all of that really mean to these 1 million New Yorkers that do identify with a disability.
So thank you, Kristen, and thank you, Jose, for pointing that out. Really appreciate that. That's what happens when you get advocates on the line, and they always hold you accountable. And certainly Jose has done that through my career as commissioner. So yeah, we care about people's life cycle. We have 1 million people, just about 928,000 people with disabilities that live in New York City, and we have about 9 million people with disabilities that come visit the city every year. And in order for people to be seen and for people to be heard, it's important for us to provide services throughout New York City that does that. Education is a big part of what we do. I might step on my colleague, Christina Foti's toes a little bit here, but there are a large amount of kids that identify with an individual education plan. And the Department of Education has the way in their inclusive classrooms to really bring kids with disabilities the equal rights that they need. And I know all the hard work is there, because it really starts with education, making sure that the kids have access to class, the tools that they need to be able to do that, and so on and so forth. And so happy to be working with the Department of Education on all their disability issues, from how they provide accessible virtual platforms, to how they're making schools accessible, to how they're providing sign language interpreters, and so on and so forth. So I know they do some great work in transitioning kids from high school into the workplace or into college appropriately. So we're constantly evolving that. And school is certainly the start of it, and really showing that people with disabilities are part of everything that we do. And I remember when I went to school, there weren't any kids with disabilities. And now we have these inclusive classrooms. So we're building acceptance and tolerance when kids are very young, and that's important. And then another good place that we can build acceptance and tolerance is in the workplace. Pre-pandemic, 79% of people with disabilities from the working age of 16 to 64 were jobless. I'll say that again. 79% of people with disabilities from the working age of 16 to 64 were jobless pre-pandemic. And the unemployment rate for non-disabled people was at like 4%. So you see the divide. So we started a program called NYC at Work. It's a public-private partnership to employ people with disabilities. And Mayor's Office of People with Disabilities have reached out to service providers. Who's looking for jobs? We have a portal that lets people connect directly for people for jobs. We work with businesses, the Business Development Council, really creating businesses, getting them involved, and really us centered out so we can have a person-centered approach, finding out how we can match people with disabilities to jobs and jobs to people with disabilities. When we're not talking about low-paying jobs, we're talking about real jobs with real pay and real benefits. And along with that is trying to understand our financial situation, because our Medicare, Medicaid rules really in a big way handcuff us from getting work. Because people have to make real decisions. I can lose my benefits if I start to work, and that's real. So we started a free financial empowerment program for people with disabilities called Empowered NYC. So any New Yorker that wants to become financially empowered has a free resource to be able to do that. And during the pre-pandemic, we hired over 400 people with disabilities in real jobs at real pay, and we've really made a difference. And during the pandemic, we've seen lots of good things happen. Those people have kept those jobs, but we also need to be cognizant that there is a digital divide, and as this world goes virtual, we need people to get connected devices. They need internet connection, and they'll be able to have the services like ASL and captioning embedded into everything that they do. And the platforms on the other side have to be accessible. And Zoom has a lot of accessible platforms, and we have worked with the Department of Education on that. So I think I'll stop there because I have a lot to say, and I know this is going to be more of a discussion, but thank you.
Well, I wanted to add that MOPD, what Commissioner Calise failed to realize, say, is that he also works with other organizations like United Spinal to match our members or members of other organizations to those really successful jobs that he's talking about. You know, he's given presentations with my organization and other organizations when it comes to the finding jobs and, you know, the Empower NYC, you know, programs to make sure that people with disabilities know what their limits and benefits are to going back to work.
Thank you, Jose. I think always add in perspective of hearing about the programs and then how they're practiced, right, in actuality. So thank you for adding that. Christina, there was a significant crossover into some of your responsibilities, you know, in the conversation. So I think only natural, you know, if I could lean into you a little bit, your department significantly working on addressing the learning loss, right? Identified learning loss and working to address it, you know, for special education students with a recovery plan. So I want to make sure you had an opportunity, you know, to share more on your work and your team's work.
Of course. Yes. Thanks so much, Kristen. And I think I'll start just by building on a little bit of what Commissioner Calise and Jose had just mentioned in terms of workforce readiness and making sure that our students with disabilities have opportunities to kind of grow and thrive, of course, within the Department of Education and be prepared for post-secondary readiness afterwards. One of the things that we really advocated for throughout the pandemic was for our 21-year-olds to be able to spend more time within the Department of Education because of for a few reasons. Number one, opportunity gaps in terms of access to the staff and teachers that typically they were with day in and day out pre-pandemic, preparing them for work readiness or college readiness, providing consultative services. And in some instances, we heard from families who weren't able to visit day hab facilities, right? Or weren't able to visit residential facilities that their 21-year-olds would be transitioning to. And of course, how can a family be expected to make a decision about what is best if they don't step a foot into a program? And so keeping those students with us, whether for credit-bearing reasons or for, as I mentioned earlier, consultative reasons, we want to make sure that they paired with a job coach, find the right day hab, have extra time in the college admissions process, perhaps. And so it's been really gratifying to be able to offer additional time for our 21-year-olds the past 2 years to have access to those services within the Department of Education. And looking forward in terms of the recovery efforts, Kristen, and all, I appreciate that question. We recognized in planning for our students with disabilities that every student has a need right now. And we need to make sure that our recovery services and our plan for recovery services is one that allows for equitable access to those services across every one of our schools. And so in the upcoming weeks, our schools will be receiving an allocation that will allow them to provide after school and Saturday school programs to every student with an IEP. And we're asking our schools to create individual recovery plans for each of those students, taking into account progress made on their IEP goals or lack thereof, taking into account attendance or lack of a device, taking into account whether or not a child's a bilingual special education student or whether or not the student was in temporary housing at any point during the pandemic. And so intensity of services and type of services are certainly going to vary by the individual child, and that is what we will use those individual recovery plans to guide us with. But we saw our jobs as being very strongly as being the advocates for ensuring that schools get the funding to provide those services after school and on Saturday or on Saturdays. Some schools may choose that. And not only to provide small group intervention with evidence-based intervention materials, but also to provide the additional related services, occupational therapy, speech therapy, physical therapy, counseling that our children really need and certainly benefit from. So we're really delighted to be able to offer those services in the upcoming year.
Thank you so much, more than I had briefed myself on, and all that you're going to deliver, and so individualized. Incredible work. Just thank you so much for sharing all of that. The Senator, if we were in person, I'd probably be able to notice, right, all your head shaking in so much agreement, but on the screen, it certainly looks like, right, there's, some agreements. I wanted to see, Senator, if you'd be able to share, you've done so much listening to the community and hearing on need and what does a really promise of progress look like. So if I could lean into you, sir.
Thank you for the question. Thank you for Commissioner Calise and Jose and Christina's comments. And there's so much there that I really appreciate every area that they went into. And I have a lot to say. I'll try to keep it brief. But I see in the comments, and I don't have an answer for this, but I went to an impartial hearing with the school district, and I actually went to state review. And by I say me, I mean my wife and I and our son, and we advocated and actually ended up winning at state review. So I think that number that's in the chat is reflective, whether we're talking about school districts or we're talking about OPWDD, that those systems are growing exponentially. And that's why, beyond all the challenges that we know exist right now, we have to acknowledge that. We have to acknowledge that we are going to be serving more people in those systems. So as it relates to things like workforce, we have to partner with businesses. Obviously, through the pandemic, it's really been more challenging, but it also, we can't allow that to be an excuse, because when we're talking about transitioning to the workforce, something I just helped my 22-year-old son do, it was not a smooth pathway. There was a lot of challenges, and he needed some support in that. And fortunately, we navigated through it correctly, but that means we have to make sure that the systems are accessible and accommodating for a variety of different disabilities. And I think that has to be acknowledged. As far as optimism goes, I will say that as being relatively new to this, now I worked through our school system and through Access VR along with my son and my wife. So I come at it from a family perspective, but I'm newly named this year to chair of disabilities. And I think what is frustrating is that all of us that exist in this world see where the gaps are, see that it's, in many ways, it's unsustainable. And the frustrating part is that the rest of the world may not know. The families know, the advocates know, the leaders of organizations know, and we're calling out loud to say that this problem must be addressed. And I do think that there's a level of effectiveness of that. I commend leader Stuart Cousins for establishing this standalone committee. But what we're trying to make up here is due to the fact that it has been forgotten, that we have not, this system has not been funded properly for a decade, and we're behind. But we have to be optimistic. We have to be optimistic. There's a different mindset. We have a new governor. We are going to have a new commissioner at OPWDD. And I do think that hopefully we're at the right point. We're at a crossroads where we're going to get that different mindset, that we have to infuse dollars into the system, but we also, have to acknowledge that there's a lot of other things that we can do, both for people with disabilities in the workforce and the people that work with people with disabilities. And I think people are listening to that. I think they're starting to listen. It's absolutely essential that that we make this a priority. We need people to be a part of an effective workforce in this state and in this country, and that's got to be inclusive to all. We have to fund it, but we also have to do some other things, I think, policy-wise, that would be smart. And anyway, I'm looking forward to, this shared commitment with everybody here to try to make sure that we are not having this conversation 5 years, 10 years, 25 years down the road, that we do have an inclusive culture that makes it accessible and accommodating to people to enter the workforce in whatever capacity they do. And that's just one area we have to work on. Thank you for letting me ramble.
Thank you for your contributions. And I took some notes as well of, again, the simplicity of the words, but yet to achieve an effective workforce. I think Commissioner also talked about it too, not just a job, a meaningful job with meaningful wages is so critical. The connectivity throughout all the conversations, is special. So thank you for being everyone so bold and so transparent. If I could go back a little bit, Gregory, and we talked about, before we get workforce readiness, we're talking through students, right? And Senator shared, his experience, as a dad and with his family, and I maybe lightly touched on mine, but the work that, Gregory, you and your team are doing, in the schools, every day, I wanted to see if you'd be able to share just, what is that work that is so needed right now? How are school psychologists really able to support, students with disabilities today? And I know you're really passionate about incorporating culture, environment, practices, right? That it's not unilateral, and they're not mutually exclusive of each other. So I wanted to hear your thoughts on that.
Absolutely. I echo some of what the senator is saying, particularly some of what Victor has said and Christina has said, and of course, Jose. school psychologists typically often play almost two roles in schools, where we're helping our school administrators and our teachers create positive school environments in school, so that students can focus on learning. So much of what we see in the community oftentimes spills over into schools. And right now, so many school psychologists and mental health teams are really, really concerned, particularly about a lot of the learning loss. We have pre-K students, kindergarten students, and sometimes even first grade students who have not seen their peers, who have not had academic learning for a really, really long time. And there is significant concern about that. And Christina has spoken really well about some of the things, and I'm sure she will speak a little bit more about what the Department of Education is doing to help that. But also, school psychologists play a really, really big role in managing the special education process, assuring that educational plans are appropriate for students. I often like to tell parents when I speak to them that we're very, very concerned, and we want to make sure that when a child has a disability, we can support that. We're always concerned about supporting our children's weaknesses, but we also want to know, what is this child's ability? How can we put this child in the best place for them to be successful? What kind of classroom set? What kind of support services do they need? How can we as school psychologists speak to the teacher about how this child learns? What kind of information best supports their academic process? How do they think? All of these things are extremely important when we are evaluating and we're trying to push our students to be the best versions of themselves. And that's really what we do along with mental health teams. There's been significant concern, not only a lot of talk in the earlier panel spoke about so much of the concern that we have for students last year who was not able to receive special education services. Students receive so much help in the building, and time away from that building has been detrimental to our children's progress. But we also want to make sure specifically that educational plans reflects our students' potentials, even after high school, into vocational training and into transitional services where our students are becoming full-fledged members of society. So we're very concerned as a community, and we want to do everything possible to make sure that we get our students back to where they need to be.
Thank you, for your work and your team's work. I think, one is acknowledging where we're at today. You can't have a future without a present, right? So thank you for addressing what you're seeing in the landscape and advising on what is to come. So thank you for your work. And I don't want to speak for you, but that you would encourage families to seek out school psychologists, that there is not a stigma for it, but to reach out for help. I think Commissioner also talked about many programs that are available, but there is help out there. There are resources out there, and New York City is certainly leading the way with support.
Absolutely.
If I think about the term support, off of that, I think Jose, I really appreciated how you opened our panel, right, with an inclusivity, advocacy, and accountability statement. But if I think about support and the work that you are doing in such collaboration, and it sounds like just with everyone on the panel, right? We haven't had the opportunity to meet in person, but it sounds so collaborative, the work. We're able to finish sentences, with Commissioner almost. But if you'd be able to share, what your perspective is, what are you seeing, in your work and an expectation for all of us?
Well, how about I talk about, a personal thing that I experienced over the pandemic. At the beginning of the pandemic, when everything was shutting down, the governor said that, only essential workers were going to be able to, go outdoors and go to work. With that being said, my home care worker, he didn't consider himself essential. he came to me and says, I'm not going to be able to come into work and ensure that you are safe from the pandemic. And me being an advocate, he should have known better. But unfortunately, home care workers are so low on the totem pole that, they automatically assume that they weren't, essential. And they never were even acknowledged as essential. I even reached out to Victor, Commissioner Calise's office, and says, this is a problem because on Monday morning, we're going to have thousands of workers that aren't going to show up to work. And we're going to have thousands of individuals with disabilities left without care. And they're going to have no support, at a time that they need it the most. Through advocacy, through the agencies, through the commissioner's office, through 1199, through home care agencies, we got the word out, and thankfully, the home care workers did show up to work, but they should be elevated to be appreciated because they kept me alive and they kept us safe. And my home care worker paid the ultimate price and died because he was traveling back and forth, throughout the pandemic, and he died pretty soon on. In mid-April, he got sick and only lived 2 weeks and died. And I was left kind of scrambling to find help for almost 3 months. Wow. So it was rough at the beginning.
Wow. Wow. Jose, I just want to add there that what I'm hearing from you is not unlike so many of the stories that mental health teams in schools, school psychologists are hearing from parents. I want to take that a step further. And even last year, having students, we, as a city, I know we tried to implement remote learning to kind of support students during the pandemic, but some of our parents didn't even have internet. Some didn't have computers. Some some didn't even know how to use computers, even if they had them, because of the families that we serve, often that come from low poverty, low socioeconomic communities. These are often also families that come from communities of colors, Black and Brown students. A tremendous amount of difficulty last year, and I'm sure we're looking to do a lot to bounce back, and it's going to take a collective effort for us to make it happen.
Oh, we need to learn from these and put plans in place so that we are better prepared to handle this in the future. This was just a glimpse. This seems to happen every so often. Pandemics, Spanish flu, we had polio, and now we have corona. This is just a glimpse of what can happen, and we should definitely be better prepared.
Absolutely. And on top of that, our communities, even prior to the pandemic, the families that we serve still struggle with a lot of the issues that they struggle with now. Our children come from families that our children can show up to school buildings experiencing some of the trauma that they're experiencing at home. Food shortage, parents who are underemployed, parents who can't help to provide for their needs, let alone the needs of their children. And so much of those issues arise in the school building. And it's something that needs to be addressed. I completely agree with you, Jose.
Jose, thank you for sharing, and of course your our thoughts, of course, for your loss and your advocacy. So critical to this conversation and the ones that we'll all have after this. It's a ripple effect, right? It just takes one. That's how the ocean rises, ripple by ripple. So thank you. I wanted to see, Commissioner, I've heard you had the privilege to hear you speak quite a bit. And I've heard you use the term, how do we squeeze the gap? If I reflect on the conversation that, over the last few minutes, there was a lot of talk about the gap and what's not being achieved and what could be better. And so if I could just lean into you a little bit on and all that, what the effort that is going into squeezing that gap in the platforms and the programs.
So, Kristen, I think maybe a lot of the stuff that I talked about gap was the gap in housing, because there's, and it goes a little something like this. There is affordable housing, and it's up here. And affordable housing, you have to make $22,000 or more to get into it. And we've done an extraordinary amount to make sure that we have accessible affordable housing available. We set up Housing Connect. We allowed a lot of people with disabilities to get into that housing. But the only way to get into that housing is to be paid the right amount of money. A lot of people with disabilities, we talked about our unemployment rate is 79%, right? So they're under that $22,000. So you got people here, which is up high, and you got people down low. And in between is that gap, right? That gap of filling that affordable housing. So how do we fix that? Well, getting people real jobs at real pay is another thing, but how do we create other subsidies to make sure that we can get people that make less money, that are under that level, that are actually living in poverty, to get into that affordable housing, that accessible affordable housing? You heard people talking about mental health and housing and supportive housing. These are people that live in poverty. We got to figure out how to fill that gap and make sure that everybody can get into that affordable housing, either be supportive housing and accessible affordable housing, because that's important. But there always is a gap between people with disabilities and the non-disabled world. Nobody cares about disability until it happens to them. And it will at some point in your life. But we, government, have the tools to be able to effectively fill those gaps and make sure that people with disabilities do not fall behind. The senator, having his hands on things and having him available to be able to understand the issues both personally and from a legislative issue. How does he fill the gap? We, the city of New York, when we're looking at things, adding accessible for hire vehicles, the ride sharing companies. For years and years, they told us, if we put the rules that you have in place, we'll go bankrupt. These are billion-dollar companies that said this, right? We, the city of New York, used the levers of what we had in government, and now there are thousands of ride-sharing cars that are available to people with disabilities that never existed. We, government, have the ability to be able to pull those to pull those levers to make things happen. It's not easy, right? There's lots of different things that come our way. The senator knows this really, really well. But if we have it and say we can do it and we make that full commitment, we will not leave people with disabilities behind. And it's addressing so many different areas, but every aspect of government has a disability obligation or it affects them. And we talk about diversity, equity, inclusion. I am all for that. But if you're not including disability and D&I, you're not doing it right. That's how those are some of the ways that you fill the gap.
And I want to go a little bit further than that, because I appreciate Senator Manion. You are the chair of the disability community, disability chair, and I've worked with a lot of elected officials, but we should fill the New York State Chief Disabilities Officer position. It's something that's been vacant, and it should be represented by a person with a disability on a state level. We have MOPD in the city level, but we do not have a representation in a state level. And until we are included in every conversation, you can never really understand and fully address our needs. Just like Commissioner Calise said, that we have housing, we have that gap in housing. Another big factor in that is that people with disabilities, whether due to birth or accident, end up in nursing homes. And because you're in a nursing home, you're not considered homeless, and we end up trapped. Someone told me something that struck me, and he said that graveyards are filled with untapped potential, but that is the same truth with those who are in nursing homes. You end up in a nursing home, you cannot get educated, you cannot do anything to progress your life. And even if you get out 10 years after being placed in a nursing home, where do you begin? You end up institutionalized. You have given up years of your life. It's just unfortunate.
I just want to add to, Jose was really talking about housing, and we've done a lot to make housing accessible in New York City. There's affordable housing units that we talked about. Very important to be able to get accessible, affordable housing. But we, the city of New York, have used our levers to make sure that any housing that is built, apartment buildings that are being built, is adaptable for people with disabilities. So basically, that means that building apartments are being built and they're adaptable for people with disabilities. So if a person with a disability moves into that apartment, a newly built apartment, they're able to turn around and adapt it, meaning they can make the doorway swing another way. There's reinforcements in the wall that allows for grab bars to be put in and cabinets to be taken out in the kitchen and in the bathroom to make that accessible housing. That is type B plus housing that we put in. And because I chair the accessible portion of the New York City Building Code, we've made those adaptations. So all new housing that is being built is, they have a segment of accessible housing, and all housing is adaptable. So again, using the powers of government to be able to move that forward.
Thank you so much. I will also, I'll try to put in the chat too, the PACT, the Permanent Affordable Commitment Together link. There's some really great collateral and the video on there too. So I will add that to the chat. Thank you so much. For sure. Sorry, Senator, I didn't mean to speak over. Go ahead.
No, you're fine. I apologize. Just in response to all the things that Jose mentioned that are so important, we need a responsive government, and we did pass legislation this year to create, the Office of the Advocate for people with disabilities. And, that's a step. It's an important one. We need to hear that voice directly. And, additionally, hearings are important. We need to hold additional hearings as it relates to housing and other issues. And I'm working with the Senate and some of my colleagues to make sure that that happens. Some of the other comments about housing, I will say, the state should support efforts for individuals to stay in their homes, to make it easier for them to be able to renovate in an affordable manner and accommodate, any of the disabilities that they might have. We also need to fund and support a spectrum of housing, that the options can't just be limited to 24/7 model or self-direction living at home with a family member. OPWDD did, through the enhanced FMAP funding in their draft plan, allocate $20 million to start an integrated housing pilot program. And I commend that. And I think that we have to have creative ideas as it comes to housing, and we have to have flexible ideas, and it has to involve choice for the individuals that are going to be living there. So anyway, just wanted to add those things and appreciate everybody's comments on this issue and others.
Thank you so much, Senator, Commissioner Jose, and Gregory. And so I struggled to find a good transition from housing, to education, but it is all connected, right? It really, if I look at Christina on the screen of just the work you have to do today, right? Well, you'll get off this panel and get right back to work serving our students, right? The next generation and the youth and all that you have on your plate. And you are, what we talked about, the investment in creative ideas and flexible ideas, I think you parlayed so much into that in your intro of looking at individual plans, staying flexible with students. Intensity levels will vary, and it will be on need based. And so I wanted to see, in our, moments together, and not to feel rushed at all, just, any other remarks on, our teacher population, our student population, and special education in particular.
Yeah, absolutely. I just, all of there's so much interconnectedness in each of these topics, and housing, whether it's from housing perspective of adults with disabilities and certainly the housing impact that our students with disabilities are having in our city. And temporary housing status, as I said earlier, certainly one of the things that we are keeping asking schools to keep at the forefront in terms of potential challenges that our students with disabilities are facing and their families are facing that could, as Gregory said, could certainly play a role in how they show up for school day in and day out. How could it not play a role, right? And so for us, creating a supportive and welcoming environment for our students with disabilities is certainly at the forefront, and not only for the students, but their families. One of the things we're really prioritizing in our plan this year is making sure that at least 2 teachers or 2 staff members, a teacher and a paraprofessional at every building in the New York City public school system are trained in interventions. And so math interventions, ELA interventions that are evidence-based and are proven to be effective, and being able to provide consistently in every building evidence-based interventions is certainly a full-fledged step in the right direction towards not only supporting our students with IEPs, but also pre-referral intervention. And then working hand in hand with academics, of course, is our social and emotional work that Gregory really spoke to as well. And we're doing a lot of work with our school psychologists to train them in anti-discriminatory evaluation practices, because we recognize that not only in New York, but nationwide, right? We've seen disproportionate outcomes for our Black and Brown students, and particularly our Black and Brown boys. And it really is on us to question the evaluation practices that have created that disproportionality, or at least at minimum have certainly been a contributing factor to the disproportionate outcomes we see for our Black and Brown boys. And so we have always been working to make sure that our psychologists really have the tools they need to make high quality assessments for our students. But post-pandemic, we all feel the increased sense of urgency to make sure that our psychologists, as well as our teachers, are really equipped to deal with the academic as well as social and emotional needs of our students with IEPs.
Absolutely. If I could just add to what Christina said, and I thought it was absolutely spot on. Something we have to acknowledge as well is that we have so many parents, so many communities who are concerned, not only, well, they're really concerned about being overclassified. As Christina said, we have a significant amount of Black and Brown students, particularly boys, who are often classified. And it really speaks to how school psychologists and educators really take cultural competency and cultural responsiveness into how we create educational plans and how we serve families. Educational plans often have to reflect a child's personal background. I love that Christina used the words extensive data. There's no such thing as anyone just saying, you know what, I think this child has a disability. There is an extensive amount of information, research, information taken from home, from the parents, information taken from teachers in the classroom, information taken from related service providers, speech therapists, occupational therapists, all come together to really inform us what is the specific issue that we're going to address for this student. How are we going to support their weaknesses and push them to be better? But there is a large community concerned about whether we are doing right by children. And as school psychologists, I want families to know that school psychologists, it's their responsibility that every child's educational rights are spoken for, are put at the forefront when we are helping children and families. We're going to do everything that we need to do to make sure that services are given in a fair manner, regardless of race, regardless of gender or sex.
Thank you so much, Christina and Gregory. And of course, I know I'm very appreciative of my daughter's team as well, right? So I just thank you so much for the work as a parent. Senator, I thought I could lean into you. I just, talking about the student population and how important it is with the families and the legacy that you have, and, the the fight that you took on, just to share anything with our families, our audience of listening on perspective here.
Sure. What I can say is that I am so blessed to have gone through the experience, but it is a challenging one. As somebody who was an educator, and my wife has her master's in special education, and she works in the world of reading intervention mostly at this point. My son had a litany of atypical behaviors, yet he also had tremendous skills. I would not be a state senator if it wasn't for going through that experience. I watched him go through intensive early intervention that was tremendous in him breaking through those atypical behaviors and gaining skills. So I'm always going to be a strong advocate for early intervention. And as was said, also, we have to make sure that our schools have the funding, to have the professionals there to be able to form the evaluations when parents, we're going to see an increase in number of people who may end up with a diagnosis. And we have to make sure that the funding is there. We need parity. We need parity for our special act schools. That's why I was proud to support that legislation and encourage the governor to sign it. I was proud to support parity and increased rates when it comes to early intervention, because it works. In a world where budgets are important and we're always fighting for being a priority, we have to acknowledge that when we invest early and we give the people the supports that they absolutely need, whether it is in the world of developmental disabilities or otherwise, that is a benefit that pays off in the long run for sure. And that's why I keep coming back to the word mindset, because we really need to shift that mindset. Mindset is one thing. We need the legislation to support it, and we need to value it when it comes to budget time as well.
Kristen, if I may add, and just to echo what the senator just said, I think it's just critical that we continue to keep an eye on the programs that we know are effective and that work for kids. What is one of the things that we are doing this year is taking our long-standing and effective program, ASD Nest program, and turning that into a pilot. So the ASD Nest program, many folks are familiar with it, but for folks that aren't, is a reduced sized integrated co-teaching classroom for students on the spectrum. And it provides opportunities for our students on the spectrum to attend class in and access general education curriculum alongside of non-disabled peers. And it's a program that is very sought after in New York City Department of Education. And this year we are piloting that for students with the educational classification of emotional disturbance. And so we are taking some students in kindergarten and creating an inclusive kindergarten classroom for them. In the this particular program is in the Bronx, where the entire school community will be trained in behavior interventions and therapeutic approaches to teaching. And we are off the bat looking to make these kindergarteners incredibly successful in inclusive environments so that they begin their school age careers in an inclusive setting and continue to grow and thrive, and ideally graduate and be able to move on to wherever their hopes and dreams take them. But it's a really exciting pilot, and we think it's an innovative pilot that will hopefully inspire folks to invest in classrooms just like this, the one that we are able to cultivate this year.
I'd like to add that there is so much research that, first of all, the NEST program is a phenomenal program that serves so much of our students who are on the autism spectrum. But there are so many other disabilities that school psychologists and mental health teams serve in schools: learning disabilities, speech and language impairments. Christina is spot on in really saying that smaller class sizes do help in relieving and helping teachers to give the proper attention to each student, particularly students with disabilities. As you know, we often make sure that students with disabilities are learning with students that do not have an in community, and we want to make sure that that community as a whole is taken care of.
Thank you. I think, Commissioner, I'll turn it over to you in a second for any closing last thoughts here, but I would just share, you know, when people ask me about Caitlin, what worries you most? And it comes back to that inclusivity, because they're like, well, is there a certain generation that makes you most nervous? And I'm like, it's her peers, because those will be her hiring managers. So I want them to get used to Caitlin today in 5th grade, 6th grade, 7th grade, so that when she's sitting across the table applying for a job, that it's how it's a member of the community. So anyway, thank you for sharing that. Commissioner, I would like to turn it to you for any closing remarks as we look to wrap and welcome our next panel.
Well, thank you, everyone, and thank you for the honor of closing here. Thank you, Senator Gregory, Christina, Jose, City and State. It's an honor to be here. And the way to make it work is make sure you think about disability across all platforms. Everything that you do. If people are not seen, they're not heard, and if they're not heard, they're not seen. That means in the classroom, that means in representation in government. But we need to hire people with disabilities. So think about, how do you diversify? How do you include people with disabilities in the process? How do you, when you're looking for consultation on disability issues, don't expect people with disabilities to do it for free. Pay people with disabilities, because they deserve to get paid for all this. We are a wealth of knowledge. We are smart. We are educated. We are driven. Most of all, we are people. People with disabilities are part of society. We're part like anything else. And we intersect with race, gender, sexual orientation. It's important to have us included. And thank you for your time. And inclusion, 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 that's what it's all about. Thank you.
Thank you. Thank you so much. Thank you so much to the esteemed panel for sharing in your time. I have the opportunity to turn it over to Kay, who will, I think, intersect nicely the next panel of community engagement. So, so welcome to the next panel, and thank you so much for the time today.
Thank you so much, Kristen, for a great panel. I'm just going to jump in really quick in between before our final panel. And thank you so much, Jose, for just highlighting the issue of accessibility with our panels. I'm just going to post a link to our Facebook feed, which does have closed captioning for those that need it. But we need to do a better job, make sure that that's clear at the top of the program and in all of our promotions. Also, just want to make one shout out to our great sponsors for this event, Someone's Community Care, CDW, of course, Getting Out and Staying Out, and the Urban Resource Institute. And now, without further ado, I'm turning it over to my colleague, Kay Dervishi from City and State.
Thank you so much, Zach. And thank you so much to everyone who stuck around for the end of the event to join our last panel of the day, Community Engagement with Aging and Vulnerable Populations. My name's Kay. I'm an associate editor at City and State New York, and I'm very pleased to quickly introduce everyone who's joining us for today's discussion. We have Lorraine Cortés-Vázquez, Commissioner of the New York City Department for the Aging, Patrick Kwan, Senior Advisor of the Community Affairs Unit in the New York City Mayor's Office, and Christopher Smith, an Acting Associate Commissioner with the Adult Community Care Group in the Division of Adult Services at the New York State Office of Mental Health. I'm very excited to be leading this panel and discussing this topic with you all. And I think just to start out, I'd love it if everyone could introduce themselves and also answer the first question for the day. Of course, we talk a lot about vulnerable people, in today's event, but I'd love to get some more of the granular definition of how you see, who are the most vulnerable people in New York's population of older adults, and why would you sort of highlight them as like particularly vulnerable? And I guess we can start with you, Commissioner, if you're happy to take this on. Commissioner, I think you're on mute.
Thank you so much. Thank you for the technical assistance. When I think about the vulnerable New Yorker, I can't help, and the topic is so apropos, thinking about the older adult. I think the older adult's vulnerability was really pronounced during this pandemic, not only because of their vulnerability towards the disease, COVID-19, their vulnerability as victims of crimes. And we saw a lot of victimization of older adults, particularly Asian American Pacific Islander adults, into numbers that we had not seen before. And when I think about vulnerability of older adults, this pandemic exposed the historic inequities in health that low income, poor communities where many older adults reside, the vulnerability there. And when I think, and when I was listening to Victor Calise earlier, and unlike what Victor said, was that no one thinks about disability until it happens, right? Or it happens to them or someone they know. Well, unlike that, everybody is obsessed with aging. However, being obsessed with aging even makes it more marginalized, because we all have these insidious perceived notions of what an older person is. And sometimes we over-exaggerate those vulnerabilities, and sometimes we ignore those vulnerabilities because we say that they're attributed to age. So when I think about the vulnerability of older adults, I think of that entire spectrum. And I think about all of the ethnic and racial inequalities that many brown and Black older adults have experienced. So when you look at vulnerability, it's like you can't look at it without looking at all of those subsections of it.
Patrick or Christopher, any thoughts on how you sort of see who are the most vulnerable in our community of older adults?
Sure. Thank you so much for having me. So one of the things I think I often think about vulnerability is when many of us have multiple identities, that we are not just someone who's aging, we're not someone who's just disabled, as the commissioner just said. And when you kind of add in the different struggles and the different layers that kind of come in, I mean, we've always known that people who are at the margins of society are frequently at the center of tragedies. And we see that time and time again, whether we're talking about COVID, we're talking about the hurricane or different instances, that people who are at the farthest of the margins are the people who are at the center of these tragedies. And it really basically have to have us, people who are in government, people who are in, in public service, to really think about like, who are the ones that we're hearing from and who are the ones we're not hearing from, and who do we need to do the additional outreach to do so. And a lot of times I think when we think of, just within my portfolio, I work on both Asian American Pacific Islanders as well as LGBTQ communities. And for people who are struggling, who are of these different identities, and at times even multiple of these identities, who are LGBT persons, Asian American with limited English proficiency, and they are aging adults, and some of whom may be undocumented. And all of that kind of comes together, and you can really see the challenges that even for someone who speaks fluent English may have trouble going like, well, where can I get help after the hurricane? Where can I get assistance for that? And there's also the limited availability of information that actually gets to them, because especially in cases of emergency and even for public health announcements, the need for current information, new information of how to keep people safe, and people do that, it needs to be the language access issue is there. And then you add to that for many of the different multiple identities people have that add to their layers of struggle and also layers of vulnerability. And that basically what I think, as someone said earlier, keeps me up at night, to basically think of the people who have this, who have these multiple struggles, multiple identities, and how they can add up together, and where it may not just be that one slice that we're thinking of, that it's not just an aging issue, not just a disability issue, not just a language access issue, it may be all of it and more.
Yeah, I agree with everything that the commissioner and Patrick talked about, but coming from the Office of Mental Health, where our focus is really on people with serious mental illness, I think to me that is definitely an extremely vulnerable population among older people. Because serious mental illness is accompanied by so many other challenges. There's a lot of functional deficits throughout people's lives. There's poverty, isolation already, which often gets worse as people age. Separation and disconnection from family, from friends, are also sometimes parts of accompanying serious mental illness, which also can get worse when people age. And then there's another point that I think is worth mentioning. A lot of serious mental illness, especially schizophrenia, is also accompanied by cognitive deficits. So in addition to being vulnerable for dementia, like many older people are, people with serious mental illness also have sometimes worsening of those cognitive deficits, which lead to functional challenges. On the other hand, though, there are some positive perspectives as well. We heard from a lot of our providers who work with older people that they also had a lot of more resilience than you might imagine. They used their life experience, their perspective, the challenges that they've been through and struggled with over their lives to kind of contextualize the challenges that they were facing during COVID, and had a different perspective. Were less bothered by it in some cases, or at least felt like it was something that they could handle. Now, the other aspect of this is that people who don't have serious mental illnesses, people who more run-of-the-mill people, also really faced enormous mental health challenges, as did we all, I think. With isolation, with worry, with anxiety, with grief, with mourning, with dealing with stress and isolation while we were, staying home, or while we were working in difficult circumstances and concerned about COVID. So we also saw a real increase in people seeking and especially older people.
Go ahead, Commissioner.
Thank you so much. Christopher, I wanted to add a dimension. The Department for the Aging's role is to dispel, all right, a lot of these myths around ageism and aging, and that is our goal. And we do it with all of these community partners. We could not do it with community partners. And I want to state something that underscores something you said, which was about dementia and some of the other mental health illnesses that are associated with aging, and how often those are overlooked, particularly in older adults, because people will say, oh, that's just because you're getting older. So that there's so much misdiagnosis or opportunities for not really treating someone well. So when we look at ageism, we see that even in the practice of health and mental health, there is this great gap and concern. As I said before, everyone is obsessed with aging, all of us. Everybody wants to have that eternal youth in this society. And yet that obsession with aging, it's daunting how marginalized older adults are. They're not only marginalized in terms of services, size of budget, and many other issues. And so that is, when you talk about a vulnerability, Kay, that's the biggest vulnerability. It's the ageism that keeps a lot of these, practices, views, perceptions in place, but also how they're reflected in our budget and some of our policies. I have to say that I am really pleased that we constantly combat this vulnerability and this discrimination, this insidious, persistent discrimination against older adults. And we, have developed recently, based on years of the work that has been done in the community, a community care plan where we are saying the 90% of the older adults in New York want to stay at home. As a matter of fact, that's a percentage that AARP has through a survey AARP encountered, that 90% of the people want to live at home and in their communities, the communities where they've raised their families, have contributed to economically, and yet they find themselves without the community resources so that they're institutionalized, further exacerbating their vulnerability. We saw what happens to older adults who were institutionalized during this pandemic. And so what we want to do is constantly come up with how is it that we build community supports so that we could, one, empower the older person, but also allow them to live in their home for the time that they're able to, with all of the support so that they can have a decent quality of life. And we have a 5-year strategic plan that was developed under this administration for the first time in 20 years, because I want to go upward trend. We can stay on the vulnerability and the deficits. I want to go upward trend. We finally have $58 million that were given so that we could expand elder services for the first time in 20 years. And it is those kind of efforts that will combat the vulnerability and also the experiences and the incredible innovation that the community care partners, those 300 community organizations that are racially and ethnically diverse, religiously diverse, who are caring for older adults every day. The kind of transition and services that they kept providing to this most vulnerable population during this pandemic was astounding. And we got, I always say, don't let a good pandemic go to waste, because we had so many learnings, we had so many new experiences that we're building on now. So when we look at the vulnerability, we also have to think of what are the solutions. And the solution is a community that is responsive to and acknowledges what the needs of the older adults are, regardless of their language, their culture, and their social economic standing.
I appreciate all the sort of different pieces everyone has sort of highlighted and sort of, just giving us an overall picture of a lot of the different areas I think, we'll be discussing today. And I guess before I get into the next question, I'd also like to remind our audience, please feel free to submit any questions you might have in the Q&A button at the bottom of your screen. We'll try to get to them at the end of the discussion, towards the end of the discussion as time permits. And I wanted to go back to what the commissioner had highlighted in the beginning is obviously COVID-19 has been particularly challenging for older adults and, highlighted a lot of the vulnerabilities with, being more vulnerable to the coronavirus, perhaps dealing with more isolation and so on. And obviously it still remains a major risk, even though we have the vaccines now, given the Delta variant. And now we're talking about expanding booster shots for older adults. Can you talk a bit, each of your sort of respective positions, to what degree the ongoing pandemic is still affecting our ability to reach vulnerable New Yorkers in terms of, keeping services going, in terms of keeping people safe? What are sort of some of the ongoing issues you guys are all facing?
Well, imagine for a community that we say social isolation is so devastating for an older population, because not only does it have a mental health impact, but it also has a health impact, social isolation. So imagine what we had to confront for those 18 months that older adult clubs were closed. We just started opening older adult clubs on June 14th. And so that is, and we now have to, as we are opening older adult clubs, we have to be very conscious of this possible contamination with this new Delta virus. And so as we're opening, and we're happy to have opened, we know that there's still a lot of restrictions that we have to have in place. We still, have guidance around the social distancing, the wearing of the mask, and all of, the encouragement of vaccinations as much as possible. And it's only until we get past this 80% mark of older adults being vaccinated, which I'm very happy that it's up to 80%. We need to get that higher. can we then fully engage and reopen services to the extent that they will be able to address a lot of those vulnerabilities that people are still facing. It's been quite a challenge, but you know, I have to say proudly that New York City stepped up to the plate, and New York City had the Vaccine Command Center, literally had mobile vans around the city, mobile vans stationed at older adult clubs and or communities of high concentration of retired adults. We also had an exceptional program that is still going on, which is a program to inoculate individuals, to give the vaccine to individuals in their home. That is in partnership with the fire department, where EMS and fire department workers go into the home, and a vaccine is available for anyone in that home, in addition to the older person. So, I mean, that was an extensive success. And then we continue to do, right now we're launching an even broader public education campaign around vaccination and the importance of it, particularly in some of those resistant communities, communities that, you know, historically have high resistance and information. But it is something that, as everyone keeps talking about recovery, and we're happy and we're enthused about the recovery, we need to have an extra step of vigilance, because this is one of the most vulnerable populations.
Yeah. And yeah, I would also add to it where it's been amazing seeing the community partnerships that kind of came out in a lot of these events. You know, we know, for example, an average Chinese grandma in Chinatown is not reading the daily news to figure out where things are happening and things like that. And that's precisely where the partnerships with the community-based organizations are extremely important. These are the folks that they know. These are the folks that they are able to have that spread of word, that they're spreading the word at dim sum, they're spreading the word as it happens. And this is why we need those partnerships that kind of happen. And one of the things that I was also deeply inspired by, not only with some of the many mobile the home visits, the mobile clinics, is that there were also events that we're taking. It's like, hey, how can we actually do an event where the main draw of it is not vaccine, but we make the vaccines available? I remember, for example, there were back to school bag giveaway events, where they also have all these resources going back to school, and they also make it available for people to get vaccines. People who, you know, would basically ignore a vaccine event, but then they came over because it's a backpack giveaway. And they were like, oh, you know, while it's there, I may as well do it while I'm in line and do it. And there was another event that I had the privilege of going to. It was an event that was done by one of the churches up in the Bronx, where they were doing a pet food pantry giveaway, and also like a pet care for the people who can't afford to getting pet care and pet vaccines. And at the very same time, they were also like, hey, you know the importance of getting your pet vaccinated. Have you also gotten vaccinated for that? And it was just incredible to see that. And there were a lot of the creatives that were happening. And I remember there was an event that was in Brooklyn that was also where they were addressing everything with a pandemic that kind of laid bare. We're having the health issue, the wealth issue, and also the need for like jobs. It was a job fair. It was, you know, for all these, for people to learn more about what jobs were available. At the same time, people can also get vaccinated and be reminded that you actually will need to be vaccinated and to get a lot of the jobs that are available currently. And to get people to get vaccinated, there were incredibly important ways that we've been able to reach people. And all of it is thanks to a lot of the community engagement work that agencies across the board, the Vaccine Command Center, all the folks who've been doing in every community on every block.
There's a couple of things I wanted to add as well. So talking about vaccines. So even though we're a mental health system, during COVID, we really mobilized our medical and nursing staff within our hospitals to do a lot of community vaccination. In the city, we collaborated with the Department of Health and Mental Hygiene, and also with other state agencies serving people with substance use disorders and developmental disorders, and really got vaccination out. We had teams that would vaccinate people in their homes, in programs, in housing programs, we vaccinated tens of thousands of individuals, which was really an exciting project. As the ability to get vaccinated in a lot of community sites improved, the demand for our services kind of dropped off, but it was really a great initiative. But talking about people who are still vulnerable and how to keep them safe, I mean, especially it's happened throughout the health system, but especially in mental health, you have to talk about telehealth and the dramatic increase in telehealth. I mean, in a matter of a week or two, we went from a baseline of about 1% of our services or less being provided by telehealth to 90–95% of our services being provided by telehealth. So there was this really incredible transformation that took a lot of energy, time, money, blood, sweat, and tears on all sides, especially on the provider system. But figuring out how to change policies to allow it and make sure people were going to be reimbursed for the services, all of those kinds of things. And it was interesting with older individuals. I mean, that access has really been the key benefit of telehealth with the pandemic. So people who are ill or are vulnerable to getting COVID, or have mobility problems, or can't leave their home, or don't want to leave their home, they could get mental health treatment in their home. And there were some bumps in the road at the beginning, and we did a survey early on, and it found that older individuals were a little slower to engage in telehealth, especially at the beginning. But over time, I mean, they adapted just like everybody else did. And often, though, they preferred audio, telephonic care more than the audio visual. I think a lot of people were more comfortable with talking on the phone than they were with video chatting. As my parents are, I try to get them to video chat, and it's almost accidental when it actually happens rather than routine. So I think those were really important trends that continue and will continue until we're in a much safer.
So Christopher, I want to respond to you. Two things have happened, right? 2 years ago, before I got here, we had 25 geriatric mental health programs. And soon with this last round of funding, we will have grown to 88, with the goal that every older adult club should have access to a mental health service provider, so that we could, one, address a lot of the issues that you raised in their community, in a place where they feel comfortable, where there's a trusted voice. And a lot of our work has been initially around destigmatizing mental health, and particularly for the older adults, because all of us have heard that horrible phrase, oh, you're just crazy, you're just old, and we have to really destigmatize that so that people could really respond to mental health services in a positive light. The other thing that we did, again, because of the vulnerability and the isolation, was to create and expand the Friendly Voices and Friendly Visiting program that we had, where we pair up an older adult with another person, sometimes most of the times a younger person, to start, dealing with some of those issues of isolation and mental health that the individual may have. And then for the technology, what we did was we gave out 10,000 tablets to people who lived in public housing, so that they could get familiar with and have access to, and we gave them a year of free internet, so that we could constantly have that engagement in the home for people who are isolated. And fortunately, now we're going to expand that to another 10,000 tablets for those people, as we start exiting the pandemic outside of public housing facilities. But with that, we do provide the training, because we've noticed too that the technology can be daunting. So those are the kind of things that we've done to address the vulnerability, the isolation, and some of the mental health challenges and needs that we have in the older adult population.
Yeah, I agree that a lot of the mental health services that are embedded in your programs are linked to satellite clinics from our licensed programs. And those are really fantastic collaborations, because not only do you have the treatment resources available, you have it in a place where, you know, somebody can, I mean, there's still going to be stigma, and then sometimes people are reluctant to go talk to the therapist, but they're good at embedding themselves into the culture of the organization. Right. And they can give a talk about different issues, and so they start engaging people in low touch, softer kinds of ways. And then, you know, they go sit in their office and somebody might come and knock on the door and say, hey, I kind of would like to talk to you about something. So it is a much more natural way
setting,
and services. And we're very excited to hear that you're reopening those programs.
And we're also very grateful to you for giving us the additional money that got us to the 88 sites. And Thrive, formerly called Thrive, now is called Community Mental Health, were the initial funders that got it from 25 to where we are today too. So it's a combination of both. Okay.
And just to jump off the telehealth piece and what you're talking about, Christopher, I mean, you know, based on the experiences you've had, you know, seeing how telehealth's use, you know, has had benefits and challenges throughout the pandemic, like what do you sort of see its role being in the future for older adults and helping them access mental health care?
Well, there was a lot of emergency flexibility that enabled everything to happen, because there were a lot of limits, both regulatory from a state perspective and payment limits from a federal perspective that really limited, especially for older adults, the ability to engage in telehealth. We were working with we have a good number of providers in New York City who their exclusive focus is working with people with older people. And we worked with the city to fund those providers to be able to go into people's homes, but it was never enough funding. So we were talking to them about, well, why can't you use telehealth? And they educated me that Medicare rules didn't allow it. And so up until the pandemic, Medicare was only available to pay for telehealth for people who lived in rural areas. And for people who you had to go into, like, the site couldn't be the home, it had to be another setting. So, and the services that could be provided via telehealth were also very, very narrow. So those have expanded during the pandemic. The settings rule, you know, it can be people in any setting, it doesn't have to be rural, you can receive the services in the home. The types of services that can be billable for Medicare have expanded dramatically. And there's a rule proposed right now that's up for public comment. So if people are interested, feel free to comment to the federal government, really maintaining most, if not all, unfortunately, but most of that flexibility, that where there's still some limits potentially are requiring some in-person visits in addition to the virtual visits, which isn't necessarily all that bad of a thing if it's clinically kind of driven rather than arbitrarily determined, which is sort of how it's proposed. So there's a lot of future for that and a lot of optimism about that will continue to be able to serve individuals with telehealth, but also in person too, because some people like in person and some people want to get out of their apartment, and some people like seeing people face to face and having a face to face interaction. And sometimes there's the need for it, you know. Sometimes people need a different look. If you're only talking to somebody on the phone, you don't really know what's happening. You don't know how they look. Have they lost weight? Are they taking care of themselves? So the audio-visual and certainly the in-person pathways to care are still going to be important going forward. Telehealth is really stuff.
I don't think we'll ever go back to just one modality of service. I think we will always now, because of the pandemic, and we realize, and I know Patrick agrees with us on this, because one, you can do state-of-the-art programming and training across multiple sites with one good a specialist, that we will never go back to just one modality. We've learned that friendly visiting has been as impactful both in person as well as virtually. The programming, educational programming, social programming, the mental health supports have also been so impactful. So what our goal is to ensure that government, we don't get in our own way and start limiting the ability or limiting the modalities under which we can, provide these services, because we know that the reach could be further and just as impactful, whether it's done virtually or in person. And we want to be able to do both. And though that was a learning, we would have not had that experience and that depth of that knowledge had it not been for the pandemic, which is why I say never let a good pandemic go to waste. But it's important, and it's government, we have to keep advocating that, to the state and to the federal government to make sure that they do not impose limitations on how we serve individuals any longer.
We're looking at it from a clinical framework, not from an arbitrary framework. It's not going to be set, you have to do this many visits or something.
Right.
Well, first it's what the person wants. If they want to be seen in person, then you need to see them in person.
Right.
And second, if there's clinical situations where you think a person might need, an in-person checkup, either you go to them or you them to see you and just for those kinds of reasons.
Right.
And I guess I did want to pull out another thread that seemed to be sort of common among everything that you all had said in terms of COVID response, which is this idea of partnerships. What lessons can we learn from all these different existing partnerships government has with other agencies, nonprofits, healthcare providers? Patrick made an interesting point while we were discussing this call. So mutual aid groups that have popped up over the past year and a half. What have we learned from partnering with those different institutions on what strategies work best for engaging older adults and reaching them with the services they might need? And I'd love to hear your thoughts on this, Patrick.
Yeah, and I think having that telehealth chat, it's a good setup for it. I think when we know that we need to change, and there were a lot of rules that kind of came with telehealth. I still remember early on and talking with some of the providers and talk about the people were trying to figure out how to do billing for telehealth. And they're like, wait, is it initiated by a provider, initiated by a patient? Is it done over just video? Is it done just over audio? All of it, and then you kind of now just go hey, that flexibility really needed to happen because previously there just wasn't the incentive, and also it was too complicated to figure out. And I think this is also where all the other things kind of come in as well. And one of the things I think that we've been able to see, a lot of the mutual aid organizations and neighborhood organizations have made it very effectively of trying to basically get resources and care very quickly. One of the things we've seen that's been incredible, especially for due to the the high numbers of anti-Asian hate, there were a lot of Asian seniors and who are basically too afraid to leave their homes, too afraid to get groceries, too afraid to go to get medical care, too afraid to basically just even go anywhere, get out of their apartments or things like that. And there were an incredible number of neighborhood organizations. There's the folks who kind of do neighborhood patrols, and there are also folks who basically organize and mobilize to basically make sure that they get a hot meal, that they get delivered, they could actually get checked in. And you also see a lot, obviously we've seen the community fridges, which in a way, I think after the pandemic, it's become almost normal. That we kind of see oh, community fridge, of course, that's what it is, and community pantry and things like that. And I think this is some of the things that I think there are lessons and also ideas of how we can help sustain some of these efforts. And we know that some of these are pretty informal efforts, and these are very informal efforts. And as people kind of start, New York reopens again, and we also try to have some, it's like, can we formalize some of these efforts and continue on some of these that have been effective? And can we make sure that, some of the organizations who are doing this will get the funding to continue what they are doing, especially when they are effective? And these are the things that, how quickly that they're able to organize and how quickly that they're able to act. And this has basically just been incredibly inspiring, just seeing what people are able to do. And I think in some of these Facebook groups and even some of the Instagram groups, that you basically could kind of name a community and can find a mutual aid group very quickly. And some of them are also organized by population. There's a group on Facebook called Core Exchange for a bunch of LGBTQ community who basically just kind of go like, hey, here's some food, here's a cabinet, here's something that people are just trying to help each other for all of that. And these are some of the things that I think like that bits of like, hey, how can we make sure that we can help sustain some of these efforts, formalize some of these efforts, and expand the effectiveness of these efforts?
Yeah, the department, Kay, I want to just respond to that. The Department for the Aging has always relied on, unlike other city agencies, all of our work is not outwardly facing. Our work is in relationship with partnerships with community-based organizations. It's always been that way. But I think what we learned and what grew out of this pandemic was their innovation and the commitment to serve, something that centralized government doesn't, innately have. Their commitment to serve enabled them to pivot in ways that they could continue to have that connection and that service, whether it was meals or whether it was through wellness calls. We did over 5 million wellness calls, during this pandemic to make sure that people were connected. And when I say we, I'm saying this community of 300 community-based organizations who did that work daily and with older adults. And they also pivoted from, congregate meals to a grab and go for a methodology. And it was constant innovation, but it was because of their commitment to serve that community that they know and that community that they trust. And, recently, as I said earlier, we've expanded the opportunity for more of those, in communities of color, in communities where we had major service gaps, and in accessibilities for older adults. So those partnerships are essential. Government cannot do it alone. And community also has their ear to the ground and have the cultural competence and the religious competence to serve a community, the community in that area.
And I did also, Chris, do you have any thoughts? I did also want to, highlight another piece that we'd sort of touched on earlier about the issue of aging in place, which is obviously very important for a lot of older adults. And I think, has been particularly highlighted because of the pandemic, given that there are a lot of challenges with long-term care, having access to other options for being able to stay at home is obviously very important for a lot of people. Can you all share a bit what remain to be some of the biggest challenges of actually being able to age in place, as so many people wish to do, but often are unable to?
The need always outpaces the resources, so I'm going to start there. And we've expanded. Now we have 31 more new senior centers or NORCs created to serve that gap. But that's not going to be enough because the aging population keeps growing. And so we need to constantly think about what additional community services are needed. So for the first year, we focused on older adult clubs and naturally occurring retirement communities. For the second year, we're focusing on home care services. And I see in the chat, there is a lot of there's a high demand. You cannot stay in your community and in your home unless you have the supports to help you with your daily living activities. And that the support of home care agencies and home care workers is essential. So in the second year of this 5-year strategic plan, the focus is going to be on home care and case management assistance, so that we can know exactly what is going to be required for you to remain in your community with dignity and safely and avoid institutionalization. And home care is essential, but there is a shortage. So a big gap for us, Kay, is that there's a shortage of home care workers. There is also a lot of discussion around the pay of home care workers, and so which then exacerbates the shortage of home care workers. And so we have to address those challenges as we move forward, because we know that is the solution for remaining at home with dignity and remaining in the community that with dignity. And then of course, the companion piece to that is home delivered meals. Fortunately, we have expanded home delivered meals, and in year 2 and 3, the goal is to expand to keep pace with the growth of the older population.
I mean, that's super important for us too. I mean, OMH is, if you look at our budget, we're more of a housing agency than a mental health agency. I mean, we have thousands and thousands of apartments in the city and across the state, where people live in apartments in the community with supports, and also congregate programs. And, it's one of these, it's not COVID related so much, but turning some things that aren't great into learning opportunities and figuring out ways to do things better. In recent years, we're trying to move people with a serious mental illness out of nursing homes into community settings, out of adult homes into community settings. We're always, we don't want people to live in state hospitals. We want them to have a clear recovery path and live in a community setting, even if they're older. So, we always want people to live in the best possible, freest setting where they can live a rich, full life. And a lot of the things the commissioner was talking about are lessons that we've learned. And a big one is that collaboration with home health, because going back to the things that I was talking about, some of the challenges that people have with functioning and with some cognitive issues, we provide mental health supports for those people, but we've had to introduce our housing providers to home care agencies and introduce home care agencies to our housing providers so they can understand how they can help each other to support people with serious mental illness who want and need to live as independently as possible in the community and need all of those resources. So that's a major focus of ours. There's the State Geriatric Mental Health Act talking about collaboration too. We run a grant program through that, but it's really a collaboration between the State Office of Aging, OMH, and OASIS, the State Substance Abuse Agency. And we're starting our next wave of programs for that in the new year. And it's focused in New York City and some of the surrounding counties, but it's focused on two things, helping geriatric, older individuals with mental illness age in place and deal with response to COVID. And it is exactly what we've been talking about. It's that collaboration between those agencies, because nobody can do it alone. Everybody needs supports and partnership and assistance from the other agencies, from other areas of government. So we have to partner, we have to collaborate, and we do. But if we don't, none of us are going to be successful in the ways that we need to be. And the people who we serve and that we care about will suffer.
It's precisely because of that, Christopher and Patrick, that we are proposing an aging cabinet across city and state agencies, primarily city agencies, because we do it a lot informally, but we know that if we, and Commissioner Victor Calise had said that earlier, he sits on the housing to look at the accessibility issues and all the housing. It's when you structure things like aging cabinets, where each agency that touches aging, one way or another, whether it's housing, whether it's NYPD, whether it's fire, whether it's, CUNY, all of the agencies that interact or have a lane in the field of aging, to form a cabinet so that we can have that cross collaboration. And we can also look at policies and start reviewing each other's policies to make sure that there are no inherent discriminations in any of those policies just because of age, and also to advance, some policies that would be beneficial to older adults. So I think you hit it, Christopher. We can't do it alone, but we need to structure it so that it doesn't become happenstance or just because I get along with Patrick or I can talk to you. It shouldn't be like that. It should be, developing the strongest policy for this population.
And I think just along those lines, speaking broadly, where are there still continued gaps with, making sure that we're actually collaborating on giving services to people that are needed. And particularly, I think, something that I thought was interesting as we were preparing for this discussion, the aspect that we have a very diverse older population, how do we continue giving also culturally competent care and, actually fully understanding what people's needs are and how to communicate with them most effectively and help them.
So I'm going to end with this, and then I'm going to throw it over to Patrick. Okay. So I want to just give you some numbers. The adult white population over 60 has remained flat. All right. And when we got the new census data, the African-American population has grown by 75%. The Hispanic population has grown double, 108%. And the Asian American population over the age of 60 has tripled. It's gone from 80,000 to I think 160,000. That growth requires for us to look at the current constellation of services and the competencies that we have built into each one of our providers to address that growing need. And that is what we know today. And that was in the last 10 years. We expect that the next 10 years that growth in those populations is even going to be greater, especially as people age in. So I think that's one of the biggest gaps, Kay, is how is it that we build the cultural competencies into the existing network that we have, and how do we expand that network so that it reflects those communities and can come from those communities to serve those communities. And then of course, the whole gap around aging in place and the need for additional support services, more transportation, more home care services, more home delivered meals, and those kind of things that will keep you supported and while you age in place and avoid institutionalization. And I'm going to turn that over to you, Patrick, now.
Yeah, I think one of the things that I think that is especially heartbreaking is around for older LGBT seniors, many of whom who may not be able to find that culturally competent care, as they basically have, not only are they reliant on the care of others, they may now be reliant on families who may not be as welcoming and accepting as who they are. There's obviously some effort, and there's some small effort of making sure that there are culturally competent care for LGBT seniors, especially for a growing population of, for a very diverse New York. And I think this is also where how that we have that lens of like when we're thinking about like aging in place, when we're thinking about all this having culturally competent care, is like, how about the other folks who have these multiple identities? How can we kind of do that? And the culturally competent care part, I think it having, providers and having, it could be from community health centers to like small family providers and all these folks and community health workers, for example. And these are all folks who were lacking before. And that now, we have COVID, that we also had a lot of disruption around that. And there's also like a need to make sure that, we build that pipeline of people who are able to provide culturally competent care to these very diverse New York populations. And we're starting to really see it. We're able to basically put up these efforts, and we're also serving as a model to other cities, to other places, to really think about like, how do we care for some of our most vulnerable New Yorkers, and who include people who are seniors, who have people with multiple identities. And I think this is where we have there, and then I think we're also have all the different advocacy groups and all the CBOs that we have in New York who are partnering, and some of whom who are not only doing advocacy but also service providers. I'm thinking of like the folks at SAGE, who the LGBT seniors, they do advocacy, and they also do senior housing for LGBT folks. And more, I think we're going to see for some of these folks who kind of have not only the expertise, but also the advocacy that's needed to make sure that more of these programs are in place. And you see that across populations of need for do so. And, when we're, every time I'm thinking of like aging in place, and for a lot of the, thinking specific Chinatown, where I grew up in New York, it's just that a lot of the seniors and, Chinatown is graying. Chinatown is like a really, really large senior population, and the housing stock of people for a lot of the tenement buildings. And even if, a lot of the seniors who want to stay there, they really can't, because the housing stock really doesn't make it possible for them. The bathrooms are not accessible. They cannot go up and down the stairs, and all of that work, that even if there is culturally competent care, even if there's home care, the quality of the housing doesn't really allow them to stay in their communities, to stay in the places who are there. And I think that's also the other aspects of like what we have to think about and see, and how we can support some of these folks to make sure that they can stay in a community, stay with the services, have that connection, that even if they have to move, if they have to go somewhere else, that this is also where that they have that connection with, not only having food and having centers, but also just having care, that how they can find that work and community.
Yeah, and Patrick, as you well know, SAGE has been really stepping up to the plate and serving as a technical advisory trainer for many of our programs, so that all older adults are not going to the SAGE programs, they're going to all of the programs. And so how is it to train the staff as well as some of the participants for the acceptance and the welcoming of the older adult LGBT population in the setting that is not targeted for LGBT?
That wraps up today's panel. We're all out of time, but thank you so much to our panelists for joining today and participating in this wonderful discussion. Thank you so much.
Thank you. Bye-bye, everyone.
Thanks so much, Kay, and thank you to all of our panelists. That was a great discussion. And that concludes our event. But before you go, I just wanted to give another shout out again to our great sponsors, Somos Community Care, CDW, Getting Out and Staying Out, Urban Resource Institute, and of course to our great events team, and to all of our panelists and speakers today. I really thought it was a very substantive discussion of all of the things affecting the most vulnerable people here in New York. So let's keep the conversation going on the issues that matter. Join us on October 6th, Wednesday at 5 p.m. as we celebrate the Manhattan Power 100. Registration is free and can be found on our website and in the chat, cityandstateny.com. And join us on October 13th at 5 p.m. for 40 Under 40 New York City edition. Registration is free and can be found on our website and in the chat. And then our sister organization, New York Nonprofit Media, is having its annual virtual checkup on October 21st at 1 p.m. This webinar is really geared towards nonprofits that need to assess the health of their organizations as we enter the next phase of the pandemic. Registration is free, of course, and can be found on the NYN website, nynmedia.com. And last but not least, I just want to thank all of you, our great audience. We really appreciate you bearing with it and attending these virtual events to really discuss the big issues that matter. And thanks again to all of our speakers and panelists. Let's see you again. I'm Zach Williams, Senior State Politics Reporter at City and State. Catch you next time.